We are live.
A very good evening, everyone. Welcome to today's session of AIOS GuruSangam 2025 to 26 edition, the session 22 on Neuro Ophthalmology. At the very onset, I would like to thank Dr. Partha Biswas, who is the president of AIOS, Dr. Santosh Hanawar, the honorary general secretary of AIOS, Dr. Manoj Chandra Mathur, honorary treasurer, for organizing these meticulously planned sessions. With us, we have the following speakers: Dr. Annapurna Kumar from Arvind Eye Hospital, Pondicherry, Dr. Shilpa Sunarkan from PBMBS HV Desai Eye Institute, Pune, Dr. Tulika Gupta from SGT Medical College, Gurugram, and Dr. Sanjana SM from Bangalore Medical College, Bengaluru. We have the expert panelists, and that includes Dr. Ambika S. from Shankar Nitrale, Chennai, Dr. Kumudini Sharma from Hind Medical Institute, Lucknow, Dr. Murlidhar Rajamani from the Eye Foundation, Coimbatore, Dr. Niranjan Pehere from Anand Rishi Netrale, Ahilya Maharashtra, and Dr. Virendra Sachdeva from LV Prasad Eye Institute, Visakhapatnam. We will be covering a variety of topics, which will include pupil pit stop, lesions along the pathway, interpretation of neurological visual fields, approach to a case of disc edema, and imaging in neuroophthalmology. Coming to the moderators, I will be the host, Dr. Nandita Trivedi. I'm working as a fellow in Arvind Eye Hospital, Madurai. And with me, the co-host will be Dr. Pranesh Ravi from the Eye Foundation, Hosur. So without further delay, I would like to call upon our first talk and calling upon Dr. Annapurna Kumar for the first talk on the pupil pit stop, lesions along the pathway. Ma'am, can we please have you?
Dr. Annapurna, humble
Yeah,
request. Can
yeah.
I? Yeah, thanks.
Can you? Okay, right. Just give me half a minute. I'll just remove this floating screen. It's irritating. Yeah,
That's okay.
that's
It will
fine.
go away. You can just click on
Ah,
the screen and start presenting. It will go.
okay, right. So, welcome everybody. First of all, I'd like to thank the AOS for giving me this opportunity 3 times in a row. In everyday clinical practice, few things localize disease as quickly as the pupil. So, if the eyes are the windows to the soul, then the pupils are the neurologist's favorite window because they are relatively easily accessible and they're surprisingly talkative. So, whether it's a subtle RAPD or a fully fixed dilated pupil, pupillary abnormalities often provide the crucial localizing value. Um, crucial localizing value that we need. So today we will take a road trip along the pupillary pathway and make strategic pit stops and see the specific pupillary features at each of these pit stops. So let's start. Now, pupillary pathway lesions. Just a minute, this thing is blocking my. Yeah, fine. Yeah, yeah. Pupillary pathway lesions may be either afferent or efferent. Now, regardless of the location of the lesion in the afferent pathway, some of the features are common to all. So, one, the pupils are always equal in size, regardless of whether the lesion is unilateral, bilateral. Anisocoria is not a feature of afferent lesions. Second, RAPD. In unilateral and in bilateral asymmetric lesions, RAPD is always present. And surprisingly, most postgraduates don't know this light near dissociation. Now, many people think that light near dissociation is only Parinods or Argyll, Robertson, Addy, etc. But see, what happens is the near reflex fibers, they descend from the higher cortical centers and directly they go to the Edinger-Westphal from the ventral aspect. So they are not present in the pupillary pathway at all. So any afferent lesion right near dissociation is always present. Okay, so the first pit stop is exemplified in this case. So we have a 29-year-old female with rapid diminution of vision in the right eye, with impaired color vision and painful eye movements, diminished vision, impaired color vision, right central scotoma, and a mild disc edema. So this is a straightforward case of optic neuritis. So the first pit stop is the nerve fiber layer of the retina, where the nerve fiber layers coalesce to form the optic nerve. So either retinal diseases like CRAO, CRVO, or optic nerve disorders are seen here. So keeping the common features in mind and this specific case, let us see the various features. So one, the vision is always diminished. Like I said, there is no anisocoria. Pupils are always equal. Only thing is, if it's a bilateral lesion, sometimes you can get, say, a bilateral simultaneous optic neuritis. In that case, there may be a mild dilatation of the pupil. Of course, in unilateral and bilateral asymmetric lesions, you get an RAPD and, of course, a light near dissociation, like I already discussed. Fundus lesions may or may not be present. For example, a retrobulbar neuritis will not give rise to fundus signs. Visual fields are always affected, and the type of field, of course, will depend on the specific lesion that is there. Other neurological signs will not be there. Just a minute. Yeah. So the second pit stop, we have an elderly male with diminished peripheral vision in the left eye. Pupils' size and reactions are normal, mild diminution of vision, a subtle temporal pallor in both eyes, and a classic bitemporal hemianopia. So this is the second pit stop, the chiasmal lesion. So again, let's see what we get here. Vision may or may not be diminished, and if it is there, it might either be acute or chronic. Invariably, when vision is involved in a chiasmal lesion, the lesion is asymmetric. Pupillary size is normal. Now, generally, in a symmetric lesion, the pupillary reactions will be normal. But in up to 40 to 50% of cases, the lesion does tend to be asymmetric, and therefore you do get an RAPD. And in such cases, of course, there will be a light near dissociation. Fundus signs may or may not be present. If they are, usually it is in the chronic stage, like in this case where the compression causes an optic atrophy. And sometimes these cases can be a differential diagnosis, say for a glaucomatous disc. Fields are again always affected, and though there may be different types of fields, the most common is the bitemporal hemianopia. Other neurological signs, of course, will depend on the site of the compression of surrounding structures. For example, if it's a pituitary lesion with endocrine effects, then of course endocrine effects will be seen. There may be diplopia or nystagmus, or if the lesion sometimes is large enough to compress the adjacent tract, then tract features may be there. And there is one more feature referred to as in a complete bitemporal hemianopia, you get what is termed the hemifield slide phenomenon. So what happens is the only available field are the two nasal fields, which are situated just adjacent to each other. And in the absence of a ocular deviation, they just sit there normally. There is no problem. But when there is any kind of ocular deviation, okay, these fields are non-corresponding fields, and therefore you get various types of symptoms related to this. It's just in a nutshell the hemifield slide phenomenon. Coming to the third pit stop, we have a middle-aged male who cannot see objects on his left side. Here again, pupils are totally normal, mild diminution of vision. Here, there is a bow tie atrophy on the left and a right temporal pallor. And here we have fields left incongruous homonymous hemianopia. Now, the moment we see a homonymous hemianopia, this is a retrochiasmal lesion. And here, our next pit stop is the optic tract. So let's see the features of an optic tract. A pure optic tract lesion, the vision is always normal. However, frequently, the lesion is large enough to say involve the ipsilateral optic nerve, in which case, of course, vision will be diminished. Pupil generally is normal. Sometimes it's very rare to elicit this. You may see a mild contralateral mydriasis, and that is termed the bare pupil, but it's not very important. What is more important is the contralateral RAPD. Now, why do you get contralateral RAPD? Okay, now each optic tract contains 53% of nasal fibers from the other eye and only 47% of temporal fibers from the ipsilateral eye. Therefore, since the greater number of fibers in any tract are from the other eye, the RAPD is seen in the other eye. This is not a very severe RAPD, mild to moderate, probably a maximum of 1.6 log units. Now, Wernicke's hemianopic pupil is there, but it's not easy to elicit because you require a point source of light that you shine from the hemianopic portion. So, more important is the contralateral RAPD. In chronic cases, again, compression, you get optic atrophy, and this is the classic features. A contralateral bow tie atrophy, an ipsilateral, a temporal pallor, or sometimes a vertical bow tie. Due to paucity of time, I'm not really explaining why you get this particular pattern. I have a slide at the end. If there's time, I'll discuss that. Homonymous hemianopia are the characteristic of tract lesions. Now, if this is complete, then there is no way to say which part of the retrochiasm portion is involved. But if it is an incomplete homonymous hemianopia, the more anterior, that is, say, tract lesions tend to be a little more incongruous. And other neurological signs, of course, will depend upon the compression of surrounding lesions. There may be even pituitary effects, optic nerve effects, or there may be sometimes some people have even demonstrated temporal lobe lesions because it's relatively nearby. So memory loss and hallucinations, etc. The next pit stop is a relatively young female who had surgery many years back, intracranial surgery, now came for routine review. Pupils were equal in size, but the left eye showed an RAPD and all other features were basically normal. So what we see in this case special is that there is an RAPD, but both the vision and the visual fields are normal. It's not something you normally expect. This is a specific condition which we shall see. Now, just before the lateral geniculate body, the pupillary fibers leave the optic tract and they travel in the brachium of the superior colliculus to reach the pretectal nucleus. Okay, so whenever there's a lesion in the brachium of the superior colliculus and or the pretectal nucleus, you get this tectal RAPD. Let us see what happens. Vision is normal. Now, vision from now onwards, vision and fields are generally normal because the visual fibers are in a different pathway, they are not involved. Pupillary size is normal. You get again a contralateral RAPD. The pupillary fibers in the brachium of the superior colliculus are exactly the same as that occur in the optic tract. So you get a contralateral RAPD, and this RAPD in the presence of normal vision and normal fields is termed a tectal RAPD. Signs, fundus is normal, fields are normal. Other neurological signs, of course, depends on what adjacent structure. One of the frequently involved is an ipsilateral superior oblique palsy. So let us say that the right pretectal nucleus is involved. Okay, the fascicle of the fourth nerve that supplies the right superior oblique runs very close to the pretectal nucleus. So this is a frequent finding. The next pit stop we have the middle-aged male with multiple metastasis. And he presented with mainly these are the positive findings, everything else is normal. So you can see the picture. There is bilateral lid retraction, mild skew deviation of the right eye, inability to look up. And when the person attempts to look up, you get jerky convergence movements. This is termed convergence retraction nystagmus, mid-dilated pupils, and bilateral light near dissociation. So we spoke up to here where each pretectal nucleus receives fibers from its ipsilateral side. Going forward, each pretectal nucleus gives fibers to both Edinger-Westphal nuclei. Okay? Right. And this area of crossing, where the crossing fibers are situated, is a transverse bundle of white matter fibers that is referred to as the posterior commissure. So, in addition to containing these crossing fibers from the pretectal nuclei, it also contains descending fibers from the vertical gaze center and the interstitial nucleus of Cajal. So, involvement of all these fibers results in the classic features of what we term a Parinod's dorsal midbrain syndrome or a Sylvian aqueduct syndrome. So, let's see what we get. Vision is normal. Pupils are typically bilaterally mid-dilated. There is a bilateral light near dissociation. Ocular signs are very classic. You get a bilateral lid retraction that is termed the Collier sign, upgaze limitation, convergence retraction, nystagmus. There's not a true nystagmus, they're just jerky nystagmoid movements, and the classic pupillary signs, that is bilateral mid-dilated pupils with light near dissociation. Other neurological signs like sometimes skew deviation and others may be present. Yeah, there are so many others, but I don't want to talk about them because I don't want PGs to get confused. Now, while we are on the subject of the dorsal midbrain, there is another type of dorsal midbrain lesion, a little more ventrally than the posterior commissure, where you get bilateral, small, irregular pupils with light near dissociation, the classic Argyll-Robertson pupil. So this is the Sylvian aqueduct. So when there is neuronal damage around the Sylvian aqueduct, we get the classic features of an Argyll-Robertson pupil. Now, if this is also in the dorsal midbrain, why here do we get small pupils? For that, you have to understand the regulation of pupillary size on the Edinger-Westphal. Now, if the Edinger-Westphal did not have any regulation, then it will continue to fire and the pupils will always be small. So now we have a supranuclear regulation from the reticular activating system via the sympathetic, which causes inhibition. So in that case, the sphincter can relax and then pupillary dilatation can occur whenever it needs to occur. Now, in neurosyphilis, in the lesion surrounding the Sylvian aqueduct, this is affected. There is an inhibition of this inhibition. Therefore, there is a continued input to the Edinger-Westphal, and therefore the pupils are small. Okay. The irregular pupils are not mandatory for a diagnosis of Argyll-Robertson, though they are frequently present, but they are not due to the midbrain lesion. They are a consequence of syphilitic uveitis. So now we finish the afferent pathway, we come to the efferent pathway. We studied in these four categories. The all just like afferent lesions, all efferent lesions have some common features. The pupil in all efferent lesions is dilated. This is in contrast to the afferent pupil. And if it is unilateral, therefore you do get anisocoria, and there is a total internal ophthalmoplegia. So the pupil reacts neither to light, consensual, or near. Okay. So let's talk first about Edinger-Westphal lesions. Now, if you can see, this is the oculomotor nuclear complex. And if you see from the right lateral side, this Edinger-Westphal is dorsal in location. And if you see from behind and above, you see that the two Edinger-Westphal are just on either side of the midline, just touching each other. Okay. And therefore, this anatomy helps you to understand why, when there is a nuclear lesion, you always get bilateral pupillary dilatation. Unilateral lesions mean it is not a nuclear lesion. The preganglionic. So the Edinger-Westphal is the beginning of the preganglionic parasympathetic fibers. So and the preganglionic runs all the way up to the CVD ganglion. Now, this is the fascicular portion of the oculomotor nerve. Fascicular portion means the portion that is within the brainstem before it emerges from it. So I said that Edinger-Westphal, always you get bilateral pupillary dilatation. However, a fascicular involvement can produce a unilateral mydriasis. Now, depending upon what other structures are also compressed, you get a whole series of syndromes and things. We will not go into that in detail. Just be aware that such a thing is present. Now, once the fascicular fibers emerge in the interpeduncular fossa, they join together to form the main nerve, which travels up to the ciliary ganglion. So, along the pathway, wherever the lesion, the pupillary findings are the same. Ipsilateral dilated pupil with total internal ophthalmoplegia. What is different is the associated findings, which can possibly help you to differentiate. So, you can have an uncal herniation causing compression of the third nerve. Here, usually the patient is comatose. There can be the classic compression of the posterior communicating artery aneurysm at the junction of the internal carotid artery. This is a very, probably the most common cause of a unilateral intracranial cause for preganglionic pupil. And as you can see, that is because the pupillomotor fibers here are in the dorsomedial location, very superficial and very easily amenable to compression by the PCOM aneurysm. The next pit stop would be in the cavernous sinus. Here, of course, if there is cavernous sinus involvement, there will be involvement of other structures like trochlear nerve and trigeminal and other things. And in the more anterior cavernous sinus, in the superior orbital fissure and in the posterior orbit, there may be additional features like proptosis, etc. Now, coming to the post-ganglionic efferent. What is the ganglion we're talking about? We're talking about the ciliary ganglion. So the parasympathetic fibers travel in the inferior branch of the oculomotor nerve. Branches go off to medial and inferior rectus. There is one branch going to inferior oblique. From here, the parasympathetic fibers go to the ciliary ganglion. And from the ciliary ganglion, the postganglionic fibers travel through the short ciliary nerves that penetrate the sclera, travel in the suprachoroidal space, and then go to both the pupil as well as the ciliary body. Now, lesions of the postganglionic efferent can either be in the ciliary ganglion itself. They can be orbital lesions, with any inflammation, compression, blah, blah, blah. It can be in the with the short ciliary nerves in the suprachoroidal space. They can get affected by any choroidal inflammation or any severe PRP, pan-retinal photocoagulation, can also result in damage to these nerves. Now, postganglionic efferent differs slightly from other efferents in the following way. It depends on whether the lesion is acute or chronic. Acute lesions are absolutely indistinguishable from a preganglionic pupil, unilateral dilated pupil with light near dissociation. In the chronic state, certain additional features we see. Okay, let's take up one by one. The tonic near response. This is pathognomonic for a chronic postganglionic denervation. Okay, so the light reflex is still absent, but the near is present, but it is tonic, and this is due to aberrant regeneration. Let us see what it looks like. So, usually the pupil is dilated. Sometimes in a very long-standing tonic pupil, this pupil can become small also. Okay. I forgot to mention that an idiopathic inflammation of the, or rather idiopathic involvement of the ciliary ganglion is what we refer to as the Addis pupil. Okay. Now, this right pupil does not respond to light, but when there is near, there is a very slow tonic constriction, and it is so strong that this pupil may now become the smaller pupil. And when attempting to look back in the distance, again, the other pupil redilates immediately. This, of course, the animation is a little bit fast, but it does take its own sweet time and redilates slowly. This is the main difference between the chronic tonic pupils and the light near dissociation of an Argyll-Robertson pupil. In Argyll-Robertson pupils, both pupils, when looking from near to far, they dilate immediately. In the tonic pupil, it takes its own sweet time. Okay. This tonic near response mainly is because of the postganglionic parasympathetic fibers from the ciliary ganglion. By the way, these are the only postganglionic parasympathetic fibers in the body that are myelinated. About 95% of them go to the ciliary body. They serve the process of accommodation. Only about 3 to 5% go to the pupil. So since there are greater accommodative fibers, they are more likely to regenerate. And in the process of aberrant regeneration, they go and connect to the pupil. So since ciliary body contraction is generally slow and tonic, that is why we get the slow tonic reaction. Now, sector palsy, sector atrophy, vermiform movements are not specific to postganglionic efferent. They can be there in others as well. Even in the acute, you can get sectoral palsy, probably a little more common in this thing, that's all. So because of the sectoral palsy, you see that parts of the pupil are reacting, parts are not reacting. And this is generally much more easily demonstrable at the slit lamp under magnification. So the vermiform movements are because of that. Next, we come to the denervation hypersensitivity. Again, it is not specific to a postganglionic efferent. It can be seen even in preganglionic pupils. This denervation hypersensitivity develops after some time, and where the pupil reacts to a 0.1 to 5% of pilocarpine. Okay. Now, whenever there is, like I said, a ciliary postganglionic efferent in the ciliary body of idiopathic origin, we call it the classic Addis pupil, seen more commonly in females, usually unilateral, and when associated with absent deep tendon reflexes, it's the Addis syndrome. Of course, lastly, iris disease. In most of the cases, the specific iris abnormality will be seen. In these first three conditions, of course, the ciliary body is not affected, and therefore accommodation per se, the person will be able to accommodate. Okay. And of course, when you instill a cycloplegic, that is also lost. So if you can recognize the characteristic pupillary features at each of these pit stops, in most of the cases, or rather in many cases, you will be able to localize the lesion even before neuroimaging. So that's it. Thank you.
Dr. Nandita, you are muted.
Okay, thank you so much, sir. Thank you so much, Dr. Annapurna Kumar ma'am, for the very elaborate presentation. And as PGs, I feel we often struggle to diagnose or come to reach the diagnosis of the lesions of visual tract. So thank you so much, ma'am, for this presentation. The talk is now open for discussion. Can we please have Dr. Kumudini Sharma? Ma'am, please give your inputs. Dr. Kumudini ma'am? Dr. Murlidhar sir, can we please have your inputs?
Yeah, thank you, Dr. Annapurna. Really, can you hear me?
Yes, sir. Yes, sir. You're on.
Yeah, so thank you, Dr. Annapurna. That was really a wonderful presentation, very systematic and ordered. I just have one or two comments to make. One is that this is primarily a PG question. I had this question when I was a candidate, when I gave my PG entrance. So the question was that can you assess RAPD in the right eye if there is a total corneal opacity? So some some of the junior PGs said no, it cannot be assessed, but actually with the consensual you can check for the RAPD. And second is about the quantification of RAPD, which is again an exam question. This primarily, I trust this is for the postgraduate. So just to cover up on some things which could be important exam questions. So you can assess RAPD if you are able to see just one pupil with the use of consensual reflex. Second is how do you grade the RAPD? So the first answer, of course, is by the use of neutral density filters. The second thing, of course, is that you have a clinical grading system which is given in Vajandas. So whether it immediately dilates or there's a lag, based on that, you can also quantify it from 1 plus to 4 plus. And one more exam question I had was in unilateral optic neuropathy, which is the condition in which you may not get an RAPD. I did not believe this until I myself saw a patient with a Leber's hereditary optic neuropathy. So in Leber's hereditary optic neuropathy, I guess you may not have an RAPD even though there is a unilateral affection. So Leber's hereditary optic neuropathy is one condition. And one more exam question that you have is, can you have an RAPD in retinal lesions? Definitely yes, because macula contains 90% of the ganglion cells, sorry, 50% of the ganglion cells of the retina, so just the macular area. So if there is a big macular scar, you still can have an RAPD. And amblyopia also can have a subtle RAPD. So these were some of the points which I felt was very useful for the exam going postgraduates. So if there are any other, are any of the postgraduates online, or if there are any questions in the chat box, you could let us know, Dr. Nandita.
Yes, sir. Sure, sir. Thank you so much, sir. Dr. Niranjan Pehle, sir, can we please have inputs from your end?
Hello. So first of all, Dr. Kumudini Sharma ma'am, it was an excellent talk. I mean, Dr. Annapurna Kumar, it was an excellent talk. I really enjoyed this. Just a few points to add. I'm sure if there was time, you would have added them, but for the benefit of postgraduates, the appropriate conditions to be ensured before assessing the pupil is very important, because unless we satisfy all those conditions in terms of where the patient is fixating, what kind of illumination we are using, how much time we spend on each eye while assessing, all those affect our conclusions. So ensuring these conditions properly is very important. And because of that, one must not trust pupillary assessment of anybody else but only yours. That is one of the fundamental rules that at least I follow when it comes to assessment of pupil. Secondly, though some of the conditions are not very common, but the examiners are very fond of asking details about those, and that includes the Horner syndrome, Parinod syndrome, Argyll-Robertson's pupil, AD-stonic pupil. So these specific pupil conditions, though they are not very commonly seen in the clinical practice, they are very favorite questions of the examiners. And Dr. Murlidhar already mentioned about assessing pupil when you have only one pupil to assess. So how would you check RAPD when you have only one pupil accessible for assessment? That's also important question. And one clinical sign, that is H pupillary cycle time, is something that is not very commonly taught or practiced, but at least I find it very useful because I used to work in a setting where access to VEP was just not possible. So I used to work in Africa for more than 6 years. So when you have subtle pupillary or optic nerve anomalies and you don't have access to OCT, that's where this H pupillary cycle time can be very useful. It's very easy to do, but because we are not taught to do it routinely, we don't do it. But it's something very useful to pick up subtle pupillary anomalies, RAPD, because to have a clinically obvious RAPD, at least 40 to 50% of the axons need to be lost. But H pupillary cycle time can pick up even before this much axonal loss has occurred. So these are some of the things to add to your excellent talk. Thank you.
Thank you so much, sir, for your input. Dr. Virender Sachdeva, sir, can you please have input from your end?
Yeah, thank you, Dr. Annapurna Kumar. That was excellent talk. I think you organized the talk with the help of the cases. That gives us an idea what to expect in a given case, and correlating with the different aspects puts into the picture how in a given patient how we can apply and what to expect in the pupils. Niranjan and Murli have also added very valid points which would be helpful both in your examination for the patient, for the postgraduates. These are very frequently asked questions. I would just like to say that many a times when we start to seeing a patient, we go to checking the grade of RAPD. But what is first important is also to see that whether the patient has brisk pupillary reactions in both eyes, that tells that maybe that these situations are likely to be fine. The second point is that to distinguish between afferent and efferent pupillary defect. So in an afferent pupillary defect, you would have the direct response in the given eye and consensual in the other eye affected, whereas in the efferent, the afferent and efferent in one eye would be affected. So that sets the tone. And then what Niranjan was trying to say that we do have a lot of armamentarium. Uh, I don't know whether there is time. I have a video where we can show that how to assess in one functional people is there a RAPD or not. But if there's no time, that's perfectly fine. We can see towards the end of the session also. And last point is that now there are devices which can give you much more information about the pupillary response. These are called automated pupillary techniques. So you can use it in one pupil at a time or both the pupils at one go. So that can help you quantify the responses. Just for as a recent update for the postgraduates for them to know, I wanted to add that.
Yes, so thank you so much, sir. Dr. Kumodini ma'am, can you please say a few words?
Okay, one thing is that important is that in cases of this pupillary reaction depends upon the how much extent of the retina or the retina is involved, you know. So like if you have a hemianopia, both the signs, then the pupil will be sluggishly reacting, though the visual acuity would be 6/6. And when there's a macular lesion, the visual acuity is very much affected, but the pupillary reaction will be so small because it depends upon the extent of field defect. There would be a small central scotoma, so pupillary reaction would be normal, though acuity would be affected. So it doesn't go hand in hand with the acuity and the pupillary reaction. It depends upon the extent of visual field loss. And secondly, though the light reflex is not there, but the near reflex is always there because it's afferent would be sensation would be carried out by the proprioceptive receptor. When you ask the patient to look at the thumb, though he's a blind, but his pupil will still constrict. So that we should know.
Yes, ma'am.
That's
Thank
all.
you so much,
Yeah.
ma'am. Thank you so much, ma'am. Ma'am, Dr. Ambika ma'am, can you please say a few words?
Hi, Dr. Annapurna, it was a very nice lecture. I just have few comments. Before going for a pupillary assessment, just go in depth for the history because there can be a simple history of chronic drug intake, scopolamine patches, and working in an atmosphere where they are exposed to atropine. Like farmers can be having some weeds, like what we call the Jimson weeds, because sometimes you can have this physiological appearance of the pupil, which should not be mistaken for a pathological entity. 20% of the times we can have a physiological anisocoria. Pupillary examination doesn't limit only with a relative afferent pupillary defect. There are much more beyond that. So the size, shape, reflex, past history, all those things has to be connected and then have to be analyzed. And the other thing is not only the reaction to the light is important because how brisk and how sluggish. Because we all are aware that when we have a monocular optic nerve dysfunction alone, we get relative afferent defect. But when both the optic nerves are affected, what do you expect from the pupil? So it is the briskness of the pupil. So it's a sluggishly reacting pupil, which we may have to look in many a times. And for the postgraduates, I would recommend please go through all the pharmacological testing. In honors, half the pharmacological testing we don't do in clinical practice, which my colleagues on the panel will agree. But it is very, very important for the examination part because half of the drugs, what they say, cocaine and all those are not available in our place. So we are not going to do these pharmacological assessments, but do know about that. And pilocarpine test is very simple. Know how to create that pilocarpine concentration, how we install in the OPD setup. That's very simple and that is very important also. And also pupil is very important in comatose patients. So in comatose patients and in neurological setups, the pupils are the key where we localize the level of lesions. So when you see a small pinpoint pupil, the lesion is in the pontine. If you see a slightly bigger, mid-dilated sluggish, like what Dr. Annapurna showed, the tectal pupils, you can place the lesion which level based on the pupil. So you should be aware of the different level of pupillary involvement in the CNS diseases also. Like as simple as a gross metabolic acidosis to an encephalopathy, we can have different grades of pupillary involvement. So remember to read the pupillary signs in various neurological conditions. So maybe these are a few points which I felt can be added in addition to the wonderful talk. Thank you. Thank you, Nandita.
Thank you so much, ma'am. Thank you to the entire expert panel for your input, and thank you so much, Annapurna, ma'am. I think the how you have elaborately described the differences between the subtle signs and the preganglionic and the postganglionic lesions. I think it's really going to benefit all the PGs and all the viewers who are watching this. Thank you so much, ma'am. So with this, moving on to the next talk. Our next talk is on interpretation of neurological visual fields. And for this, Dr. Shilpa Sonarkan will be presenting. So can you please have Dr. Shilpa, ma'am?
Yes. Am I audible?
Yes, ma'am, you're audible, ma'am. Your
Screen
screen
is
is visible.
visible? Yeah,
Yes,
okay.
ma'am.
So, good evening, everyone. And at the outset, I would like to thank AIOS for giving me this opportunity. And today, I would be talking on interpretation of neurological visual fields. So, as we all know, is my slide moving? Yeah. Yeah.
Yes,
So,
ma'am.
yeah, as we all know, that it is very important to advise a neurological a perimetry in a case of a neurological patient with a neurological problem, and it is crucial in diagnosing, in localizing the site of lesion, and also in following up the patients who have got any neurological signs and symptoms. And many a times we have been able to diagnose a ICSOL infarct or something sinister based on the perimetry test, which has been life-saving for the patient. And it also becomes easier for postgraduate students when they follow some basic steps to understand the interpretation of visual fields, along with knowledge of basic anatomy and some signs and symptoms associated with the site of lesion. So when you have all these three things, a very good history, signs and other signs and symptoms which are associated, neurological signs and symptoms, and a perimetry, it could be a very useful tool in diagnosing. Also, it can help your radiology and neurology colleagues to point out the site of lesion. So before starting the test, it is important that the patient should understand the test and should be able to do the test, should have a good visual acuity to see the targets, and both eye fields should be tested simultaneously. And when we interpret the perimetry report, we have to keep the perimetry reports like this. So the right field lies on your right hand side, and the left eye field has to be kept on the left hand side. So this is how you keep your perimetry and then start the interpretation. So once we start the interpretation, first of all, we have to look into the reliability indices, because if there are a lot of false negative error, false positive errors, or fixation losses, then it can give to fallacious information, fallacious pattern, and then maybe you may interpret it wrongly. The next thing is what is the type of field defect, whether it is a central field defect, like a central scotoma or a centrocecal scotoma, or it is a field defect which is something like respecting a horizontal midline or a vertical midline. So like a field which affects the horizontal midline, like a altitudinal field defect, can happen in a patient of NAION. And a lesion respecting the vertical midline can happen in lesions passing from the chiasma up to visual cortex anywhere. The next thing is whether the field defect is unilateral or bilateral. So if you see you have ordered both eye fields, but you see lesions only in one of the eyes, then it could be because of the lesions of the retina or the optic nerve. So it is very crucial to do a dilated fundus examination. Sometimes it could be a glaucomatous field loss, sometimes it could be because of retinal detachment, sometimes it could be BRVO, sectoral field loss, which can mimic quadrantopia. So if it is only in one of the eyes, then you have to do a dilated fundus examination. And if it is bilateral, then you have a suspicion of respecting vertical midline, then it could be a neurological field defect. Now, this is how the retinal fibers are arranged and represent in the different parts of the starting from the optic nerve up to the optic radiation. So the nasal, the macular fibers are more nasal in the optic nerve, and then they become more central in the chiasma, and more superior in the optic tract and geniculate body, and again become more central in the optic radiations. Now coming to the lesions of the optic nerve can be affected in different situations like optic neuritis, any trauma, any space occupying lesion, or in a case of IIH. So whenever there is optic neuritis or any inflammatory lesion, it may cause a anopia in that eye. The other eye field may be normal if it has not been affected earlier. And sometimes when there is any trauma or any space occupying lesion which is just before the fibers cross the chiasma, just where the in the optic nerve, where some fibers cross to the contralateral, make a loop. It is called as von Willebrand's loop. So it may produce complete anopia of one eye and a junctional scotoma in the contralateral eye, superotemporal field loss in the other eye. This is because of the inferonasal fibers of the ipsilateral eye crossing in the contralateral side. So it may cause a junctional scotoma. It will also have pupillary response would be affected, but the near accommodation reflex would be present. And the third condition is a IIH, where you may get a enlarged blind spot, which is useful. Sometimes the neurologist will get will ask you a fundus photo and a visual field test, which is also useful in monitoring the progression or progression of the disease, so that when there is decrease in the blind spot, or when the blind spot reduces, then we can guide the neurologist uses it as a guide to change the treatment, taper the medications, taper the doses of the medications. Now, the next thing is to look whether the field defects is a heteronymous field defect or a homonymous field defects. So heteronymous field defects means a bitemporal or a binasal field defects. So here bitemporal field defects usually happens in a case of a chiasmal lesion. So chiasmal lesions can happen, could be suprasellar aneurysms or a tumor of pituitary gland like a pituitary adenoma, craniopharyngioma, or a sphenoidal meningioma, or sometimes hydrocephalus. So bitemporal hemianopia, what would be the presentation? Along with bitemporal hemianopia, the patient may also have optic atrophy, bitemporal hemianopic loss of pupillary reflexes, and there can be temporal desaturation of red color. So here in this case, to look for red desaturation, sometimes the visual fields confrontation test is better than using the red target is better than the perimetry, because the red desaturation can be appears before the actual perimetry changes happen. So confrontation test should always be done before taking a perimetry test in the clinic, because sometimes it may also be helpful in patients who cannot do a HBF test, or who have a very poor vision, who are unable to sit for the perimetry, and sometimes in cases of hemi neglect, wherein the patient have some cases of trauma or a stroke, where they do not identify or do not look into the opposite field. So in cases of in hemi neglect, you can do a confrontation test, and sometimes all these situations are there when where confrontation test can be helpful. Now coming back to the perimetry in the chiasmal area, even in the chiasmal area, the lesions could be superior, inferior, more anterior, or more posterior. So some of the commonly associated lesions of the superior chiasma, like craniopharyngioma, and it will cause a more of a dense inferior bitemporal field defect, whereas the inferior chiasmal lesion, which can happen because of lesions like pituitary adenoma, will have a dense superior bitemporal lesion. Anterior chiasmal lesions can happen because of a sphenoidal meningioma, and they can present like a junctional scotoma because they are more anterior, and more posterior chiasmal lesions can happen in a case of hydrocephalus, and they produce more of a central bitemporal field defects. So this is not always hard and fast that you will get this kind of picture. It also depends on the size of lesion, but this is how usually it starts. Then slide. So now this was about the heteronymous field defects. Now the homonymous field defects could be congruous or incongruous. Now this is a case of a homonymous field defects, which respects the vertical midline, and nasal field of one eye and temporal field of one eye is affected. So whenever you are looking for a homonymous field defect, you have to look whether it is a complete field loss or a incomplete field loss. I just forgot about the binasal hemianopia. Yes, it can happen. It is very rare, but it can happen in a case of third ventricle enlargement or an aneurysm arising from a internal carotid artery, which can cause lateral compression. Now coming back to the homonymous field defects, it can be it is incongruous field defect. It can arise from anywhere from the optic tract up to the visual cortex, and if the lesion is in the optic tract, it can cause optic atrophy. It can also cause hemianopic pupillary response, in which which is called as a Wernicke's pupil, in which the pupillary reaction is absent from the area of the loss of the field is the pupillary response is absent from in the area where the field loss is present, usually associated with tumors of thalamus and posterior and superior cerebellar artery aneurysms. Then this is how the remaining homonymous hemianopia picture conditions can be present. More anterior the lesions, the field loss is incongruous, and as you move more posteriorly, the lesions become more congruous because the fibers become more condensed, and hence the congruosity of the lesion improves. Now this is the whole visual from how the retina to the visual cortex, how the pathway goes. Now, coming to the lesions of the optic radiations, the optic radiations can have, when the inferior fibers of the optic radiations are affected, it causes in the area of temporal lobe, which is also called as Meyer's loop, it can cause a superior quadrantopia, which is also known as pie in the sky. And the neurological signs which can be associated with it are agraphia, agnosia. Patient can have acalcula, right, left, disorientation. When the superior fibers of the optic radiations are affected, it can give a picture like a inferior quadrantopia, and the patient may have neurological symptoms like memory loss, olfactory and auditory hallucinations, dysphagia. All these things you may look for when you are looking for, when you have seen the field, and you may also go back and do the neurological assessment to look for this. And if the entire optic radiation is affected, then it may cause a homonymous hemianopia sparing the macula. But how do you differentiate a lesion in the optic radiations and the optic tract, or for that matter, lesion in a lateral geniculate body versus a lesion in the optic radiations? So if the lesions are more posterior, there won't be any optic atrophy and there won't be any RAPD post the optic tract, because the pupillary pathways, they go up to the superior colliculus in midbrain after they exit from the optic tract. So only the lesions up to the optic tract will have the pupillary RAPD in patients, and beyond that the patient will not have RAPD, and even the optic atrophy would be absent. Then this is a left-sided homonymous superior quadrantopia, which is also known as pie in the sky, and which corresponds to a right-sided temporal infarct. And this is the case of a left pie on floor or inferior quadrantopia, which corresponds with a right-sided parietal lobe lesion. And sometimes there can be a sectronopia due to pathology of the contralateral geniculate nucleus, and left homonymous quadruple sectronopia due to pathology of the anterolateral anteromedial parts of lateral geniculate nucleus. Then the lesions of the optic radiations, as I just told, the fibers in the temporal lobe is called as Meyer's loop, and it was in the parietal lobe, it's called as the Baum's loop, and it leads to pie in the sky, and in parietal lobe it causes pie in the floor. This is how the fibers in the optic radiations are arranged. Now, last is the lesions of the visual cortex. So, in visual cortex, there is a dual blood supply from the posterior cerebral artery as well as the middle cerebral artery. So, macular fibers are mostly present in the occipital cortex. So, when the posterior cerebral artery supplies the posterior cerebral artery supplies mostly the anterior part of the visual cortex, and hence whenever there is a posterior cerebral artery occlusion, you can get a macular sparing congruous homonymous hemianopia, because it still gets the blood supply from the posterior middle cerebral artery. However, when there is a direct injury at the tip of the occipital lobe, as in head injury or a bullet injury, then you may get a congruous homonymous macula involving field loss, congruous macular field defects. And the most anterior lesion of the visual cortex, which involve the contralateral nasal fibers, can cause very small temporal crescent kind of field loss. So and of course there will not be any RAPD and no optic atrophy in lesions of the visual cortex. So this is how we localize the lesion in a case of neurological field loss. And I would like to thank for your patient listening. Thank you.
Thank you so much, Shilpa ma'am, for elaborately discussing the various visual field findings and how they can be integrated with the clinical findings and the neuroimaging to reach the diagnosis correctly. So the topic is now open for discussion with the expert panelists. Can we please have Dr. Ambika ma'am to give her input? Dr. Ambika ma'am?
Yeah. Thank you, Dr. Shilpa. That was an excellent talk. I just have few comments. And do you always, what type of visual field analysis you recommend for neurological assessment? Could you elaborate on
30-2.
that?
30-2
Is it
is
always
what
30-2?
mostly we do a 30-2. But when we suspect a peripheral, more of a peripheral, then of course we have to go for a wider field, cover a wider field area, then you can do a 60-2 also.
Yeah, because most of the time we do have the 30-2 programs for the automated perimetry, but nothing is equal to even a simple confrontation field testing
I'm
because
sorry to
in
interrupt,
the
Dr.
clinical,
Shilpa, can you just stop the share, please?
Yes.
may I?
Yes, ma'am, please go ahead.
So it is also very vital to do a confrontation field when we don't have this sophisticated automated programs. So the other conventional Goldman, I don't know how many of us are still having that wonderful tool in our visual field and assessment, because that is very useful in many a times. And similarly, we also have to get a diagnostic decoding for a constricted visual fields, because when there is an advanced constricted visual fields, it can happen from a advanced compression secondary to selamas or a chiasmal involvement, so or a higher cortical involvement to a malingerer. When we have this Jerem screening, where we have that beautiful tunneling of the vision, because that differentiation is very important when we have to differentiate a malingerer versus a pathological condition due to neurological cause. And that point I wanted to make, because visual field assessment is very vital in such conditions also. And the other thing is we can also get central hemiscotomas in chiasmal lesions when the involvement is more towards the posterior and the macular involvement. And these conditions can have a negative neuroimaging. And another important point is not all the time bitemporals is going to fish out a lesion in the chiasm. Ask for a history of having a chronic drug intake like ethambutol or any other drugs which can cause dense paracentral defects which can mimic a bitemporal, because that is very important. And I think many of my colleagues will agree that there are times where we expect a lesion at one particular level, but your imaging turns out to be negative. So these patients, you have to be careful and see whether have we done the appropriate neuroimaging for the level of lesion. Because if there is an inadequate imaging, we may lose the lesion also. Thank you.
Thank you so much, ma'am, for your input. Can we please have Dr. Virender Sachdeva for his input, sir?
Yeah, thanks, Dr. Nandita. Wonderful presentation, Shilpa. You gave very good examples. So when we are doing visual fields at that time, most of the time in neuro ophthalmology, the most important role that we ascribe to visual fields is the role in localization. As you said that we see visual fields of both eyes together. We put the right side on the right side, left on the left, and then try to interpret what we are getting. So there's some of the books write it, and some of the experts speak it like that. You can interpret visual fields in 7 steps. So first thing is that look whether the fields are reliable or not. If they are reliable, is there a field effect or not? And if the field effect is there, it is in one eye or both eyes. The point here is that if it is in both eyes, is it respecting vertical or horizontal meridian? If it is, there is a respect of vertical in both eyes, it has to be chiasmal or retrochiasmal. So beyond than that, it can be in if it is unilateral or it is bilateral horizontal, the problem has to be in the optic nerve and the retina. Whereas if you start getting a respect for vertical in at least in one eye, then you start getting the chiasm and retrochiasmal. So I wanted everybody to remember that. And then as you try to highlight with different examples, if it is vertical with bitemporal, you're looking at a lesion focusing at bitemporal. It's bitemporal for lesion localizing to the chiasm. If it's homonymous, you try to localize where it is. Quadrant anopias are one feature. Completeness and congruousness help. And you look at special features like macular sparing that you highlighted in the occipital lobe lesions. You also highlighted that the all pituitary tumors may not have only bitemporal but other kinds of features. So this is one aspect I wanted to highlight. The other thing, as Dr. Ambika was trying to tell, that not all patients with bitemporal would have only a pituitary tumor. So there is a mnemonic. You could remember it as VOTATE. There can be a vascular lesion. There could be a tumor. There can be thimertal toxicity. There can be demyelination. And there can be other causes that can sometimes be there that can present like that. Yeah, so one of the forms of optic neuritis that would usually affect the chiasm and can still cause bitemporal hemianopia is something that we see with patients with NMOSD. And at times, one more thing which can cause a confusing pattern is a very large centrocecal scotoma that may mimic like a bitemporal hemianopia. The last point I would like to say is that visual fields have much more value as well. In a given patient, like in glaucoma, if you see progression is happening, it means that your disease might be worsening. For example, if it's a compressive lesion, you might be having increased depth of the visual field effects that would go on to suggest that the tumor is possibly increasing in size and the patient might require a treatment. And if the patient has already operated and now there is again a recurrence of field effect, then you could be suspecting that the patient is actually having a recurrence of the tumor. So think about the other aspects of the visual fields. Lastly, confrontation fields does have its own value, even can be done even at bedside. And there are again automated visual fields which are becoming available that can be taken to even ICUs for doing it. Thank you.
Thank you so much for your inputs and thank you for reinforcing the basic things that we're taught in our OPDs at the first place to help us localize the lesions. Thank you for your input, sir. Can we please have Dr. Niranjan Behere, sir, for his input?
Yeah, so to start with the question that Dr. Ambika ma'am asked, the right strategy. So in neurological fields, we don't want the exact point threshold. So a full threshold strategy may be quite taxing for a patient who is recovering from stroke or who is having a brain tumor and is having headache. So most of these neurological patients, they have little attention span. So in those patients, we could use screening strategies. Here, the pattern of the field loss is more important than the exact point threshold. So screening strategies are also useful. And again, the importance of confrontation test cannot be overestimated, especially for the postgraduates, because if you are able to interpret Humphrey's visual field very nicely, but you're not able to do the confrontation field exactly the way it is supposed to do, I don't think the examiners will let you pass. Simple things like the patient should fix into your eye, patient should not move the eye. So those instructions need to be verbally given and made sure that the patient understands them well. Though some of these lesions, like Mayer's loop, von Willebrand's knee, they may not be seen very commonly, but they are quite favorite questions in Viva. The next thing important is the examiners may show you some field effect and they ask you, what would you do next? So straight, one should not go and say, I would do an MRI. So first, they expect you to say, what would you do in the clinic? That is, I would assess the patient's visual acuity, color vision, pupillary reflexes, I would assess the fundus properly to look for any disc pallor, disc edema, and also systemic examination. Like a patient with hemianopia may have hemiplegia or hemianesthesia, or he may be having some other very profound symptoms like alexia, agraphia, prosopagnosia, or some hallucinations, which cannot be ignored. So before jumping on to neuroimaging, one should look for all these things. So I think Shilpa had covered everything very nicely. So these are just a few peanuts to add. Thank you.
Thank you so much, sir. Can we please have Dr. Kumodini, ma'am? Ma'am, can you please say a few words?
Okay, like Dr. Shilpa has covered most of the points, but something I would like to say, like pituitary lesion, which causes to start with, it causes supratemporal quadrantinopia, and then it extends to the inferior temporal quadrant of the visual field. So while in the craniopharyngioma, it starts from the inferior temporal and goes up to the supratemporal area. So whenever there is a progression, one should know this in the pituitary lesion. The progression of the field defect in the right eye is the clockwise, and the left eye is the anti-clockwise. In the right eye it's a clockwise, and the left eye is anti-clockwise. While in craniopharyngioma, it is the reverse, because it's starting from inferior temporal and going to up to the superior temporal. Secondly, one point is also important, like the extent of nasal retina is more than the temporal retina. So there is this very much peripheral part of the nasal retina which doesn't have a corresponding area, corresponding temporal area of the retina in the other eye. So the extreme periphery of the nasal field doesn't have a corresponding field, temporal field. So hence there is a temporal crescent, which is a monocularly represented. That is called monocular temporal crescent, which is represented in the anteromedial part of the calcarean fissure. Anterior most, like posteriorly, mainly the macular representation, then the peripheral field, and the anterior most in the sulcus, calcarean sulcus, is their temporal crescent presentation. So whenever the lesion, which is only in the anterior most part of your calcarean fissure, the temporal crescent may be only affected. So that you can make, and sometimes complete cortical blindness, like there is a complete lesion in the center, the peripheral field is involved, but only the anterior is preserved. So there is a temporal crescent which is only preserved, while the rest of the field is affected. So these cases you can diagnose only by Goldman perimeter, by doing the kinetic perimeter. Sometimes the temporal field is supposed to be more extensive than the nasal field. Nasal field, but it would be reversed because there is a temporal crescent loss when there is an anterior most involvement of the calcarean fissure, and when the posterior lesions are there, the anterior crescent is anterior most representation in the calcarean fissure is preserved. So this temporal crescent would be only preserved, that the rest of the hemianopia would be there. Then temporal pole, when there is a lesion, this Mayer lobe doesn't extend to the anterior temporal pole. So for any lesion to be of the optic radiation, the temporal lobe, it has to be beyond 2.5 centimeter or 4 centimeter from the temporal pole. And so you can resect the temporal lobe, anterior pole temporal lobe, without causing any visual field defect. Then tumors are common cause of visual field defect in the parietal and temporal lobe, while in the occipital lobe, these are the infarct or the strokes are common cause of visual field defect because of the occipital lobe. Then macular sparing, she said rightly, it's a dual blood supply by MC and PCA. But another cause is also, they say, vertical meridian, vertical line which divides the retina into temporal and the nasal is not a line, it's an area. So there's a mixing of crossing of the some of the axons, and some of the axons that do not cross. Like there's a mixing of crossing of the axons on one side, and some of them which are supposed nasal fiber which are supposed to cross to the other side may go to the same side, and the one temporal which are supposed to go to the same side may cross and go to the other side. So you can say the macular sparing, the another cause is the bilateral representation of the macula. And this is sparing is using less than 5 degree in extent. And you can test this whether this is a patient fixation problem you are getting this macular sparing, or this is really a macular sparing but moving the finger, two fingers of ours, one in the central, keeping in the central part and other in the peripheral part. The patient with the moving which is toward the center would see first before the one which is coming from the peripheral side. So that's and the lateral geniculate body, those she said, those sectornopia, horizontal sectornopia, and this quadruple homonymous hemianopia. These are mainly because of the typical vascular blood supply of the lateral geniculate body. The hilum area is supplied by your lateral choroidal artery from PCA, and while your both the other areas of lateral geniculate body are supplied from anterior choroidal artery of ICA, so that they have a different blood supply. The which blood vessels is occluded, the field defect result. And another thing that sometimes they ask what OK and response. So when there is a homonymous hemianopia by occipital lobe lesion, we know occipital lobe lesions are neurologically silent. It's mainly the visual area which is represented over there. By rest of the lobe, there are associated neurological findings are there. So in the occipital lobe lesions, homonymous hemianopia, opticokinetic nystagmus is preserved when you move the drum in the whole field of the patient. While in parietal lobe lesion, homonymous hemianopia, because the parietal lobe lesion, opticokinetic nystagmus shows asymmetry. Okay, when you move it from the affected side to the normal side, there would be the asymmetry of this opticokinetic nystagmus. That's the only points from my side.
Thank you so much, ma'am, for covering all the points. And can we please have Dr. Muralidhar, sir, for your inputs?
Yeah, I think very valid inputs and a nice presentation from Dr. Shilpa. So I just have a few points which may be useful for the postgraduates. So one is that the examiner often asks what to do if the pupil is dilated. Can you still do a visual fields or not? So we must remember that the 30-2, the normative database of 30-2 was collected in patients who had pupils which were physiologically normal. They were not dilated. So the threshold comparison cannot be done, but a supra-threshold strategy like a 120-point screening, which also tests the extreme periphery, that is still possible if the patient has pupils dilated. The second point for the postgraduates is how to differentiate a glaucomatous visual field from a neurological visual field. So before you jump into saying that the neurological visual fields respect the vertical midline or the horizontal midline in longitudinal field defects, so you first need to tell the examiner that this has to be correlated with the overall clinical picture. So if a patient has other signs of glaucoma like a raised IOP and a typical notch or an acquired pit of the optic nerve, typical cupping, and that is correlating with an arcuate or a biarcuate scotoma, then that is very much relevant. It possibly points towards a glaucomatous visual field, whereas one that respects the vertical or horizontal midline is unlikely to be a glaucomatous visual field. Likewise, if you have a central or a centrocecal scotoma, in that case also a neurological cause is more likely, especially when there is an associated color vision loss, because color vision loss occurs very late in glaucomatous optic neuropathy. But please remember that in normal tension glaucomas, the field defect tend to be very close to the fixation. So you may get something like a central scotoma. So this exception has to be told to the examiner. The other important point that the examiners love to ask is, can a patient have very severe vision loss, unable to read the letter chart, but at the same time be able to navigate around with ease? So that is very much possible. So what we call as the Anton syndrome. It was first described in World War II victims who had bullet injuries to the occipital lobes. So in patients with occipital lesions, you have what is called a statokinetic dissociation. That is, the patient is able to perceive moving targets, whereas the patient may not be able to perceive static targets. And there is also what is called a denial of blindness. So the patient really is able to move around and denies that he or she is blind. Sometimes they may get phosphenes as well. So they are able to perceive moving targets with these. So which is also the basis of using a rocking chair. Yeah, that is another important exam question. So what do you do for patients who have bilateral occipital lobe lesions? So because of a statokinetic dissociation, they are able to perceive moving targets, whereas they may not be able to perceive static targets. So if you give them a rocking chair, So they could sit in one place, rock their chair around, and they may be able to see some part of the surroundings. So that is another favorite exam question. The one more thing is the examiners tend to ask is the patient says that at a particular distance, this was actually taught to me by Dr. Gordon Plant, one of the most famous neuro-ophthalmologists. So at a particular distance, they in one half of the visual field, they feel that the images are grotesque and are grossly distorted. Whereas before and after that distance, they do not perceive anything and the visual fields are perfectly normal. So in these patients, you may have a teeny part of the occipital cortex that is infarcted. So the remaining occipital cortex tends to fill in the this thing with some kind of a grotesque picture. So the visual fields can actually be normal. So if the patient complains of distortion of objects at a particular distance, which are not able to explain by a retinal lesion, and even if the visual fields are normal, so you may want to get a neuroimaging done to see if you pick up a tiny infarct. This can happen in lesions of the occipital cortex. And of course, as Dr. Virender pointed out, and Niranjan pointed out that there could be other neurological signs, like in parietal lobe, you may have something called balance syndrome. I do not want to cover it in detail, but please, you also have to say that there could be associated neurological signs. And sometimes balance syndrome can occur in the absence of a visual field defect. So depending on which area has been involved, if the optic radiations are also involved, you can have a field defect. If not, you may just have the visual symptoms.
Thank you so much, sir. So your inputs are really going to be very helpful for our postgraduates and viewers watching this. Thank you to the entire expert panel for for your input. Moving on to the next talk. Our next talk is by Dr. Tulika Gupta on the approach to a case of disc edema. Can we please have you, ma'am, Dr. Tulika Gupta, ma'am?
I'm just sharing my presentation.
Yes, ma'am.
So is it visible?
Yes, ma'am, it's visible, ma'am.
Okay. So good evening, everyone. Today I'll be discussing should we approach a patient who has disc edema. So first of all, we should understand that edema is a sign. It is not a diagnosis. So edema can be of uh, uh, first we will get to know what is papilledema. So papilledema is a term we should be very sure about. So papilledema is actually optic disc edema, which is associated with raised intracranial pressure. So that is only papilledema. Disc edema, which is not associated with increased intracranial pressure, is never papilledema. It might be ischemic, it might be inflammatory, it might be toxic. Other than that, we have a term called as pseudopapilledema. So in this, we have a structural elevation, but actually there is no edema of the disc. There is no other factor which is leading to optic disc edema or fluid will be raising the disc. The disc is anatomically like that only. So we have a 3-question clinical approach for this. First, we have to understand whether the edema is true or not, whether it is a true edema or a pseudoedema. Then we have to go to the structure and function dissociation. We have to see whether the edema is present and the vision is correspondingly decreased to the edema, or it is normal. And then we have to rule out any local causes for this edema, or we have to see whether any intracranial causes are there for this edema. Now, as we have said that we have a term called as pseudopapilledema and we have a true optic disc edema. So true optic disc edema can be due to various causes. I'll just be elaborating the various causes. First thing is the papilledema. Papilledema is due to is disc edema which is associated with increased intracranial pressure. So the various causes of papilledema can be idiopathic intracranial hypertension, intracranial tumors, hydrocephalus, cerebral venous thrombosis, meningitis, or head injury. Second most important cause of disc edema is demyelinating or inflammatory disorders, which contains optic neuritis. Optic neuritis can be multiple sclerosis associated, And we have certain atypical optic neuritis which are now being seen in our clinical practice. So we have neuromyelitis optica spectrum disorder and myelin oligodendrocyte glycoprotein antibody associated optic neuritis. Then optic neuritis can be post-viral or post-vaccination, mostly seen in pediatric population. Other causes are ischemic optic neuropathy, which can be non-arthritic anterior ischemic optic neuropathy or arthritic anterior ischemic optic neuropathy. Then we have vascular or systemic causes consisting of malignant hypertension, severe anemia, vasculitis. Infectious optic neuropathy can also be seen due to tuberculosis, syphilis, Lyme disease, or viral causes can be there like herpes simplex, varicella zoster, or measles. Compressive optic neuropathy can be due to optic nerve glioma, optic nerve sheath meningioma, pituitary adenoma, orbital apex tumors, thyroid eye disease. Then we have certain drugs which or nutritional deficiencies which can lead to optic neuropathy like ethambutol, isoniazid, vitamin B12 deficiency, infiltrated neoplastic diseases like leukemia, lymphoma, metastasis, or sarcoidosis may also lead to this. Then traumatic and miscellaneous causes are also there. Now coming to a disc which appears to have disc edema but is not edematous. So it is basically an elevated appearing optic disc without true optic nerve head edema. So what are the causes of this pseudopapilledema? The causes can be optic disc drusen, congenitally small optic discs as in hypermetropia, then tilted optic discs seen in myopia or astigmatism, myelinated retinal nerve fibers, optic disc hypoplasia. So very commonly in clinical practice, we see patients with one of these disorders maybe, and the disc appears to be elevated, but is actually not edematous. So we should know what are the various causes, and we should proceed with our investigations only after ruling out these disorders. So these are the various pictures which show us that on the top left you can see tilted optic disc. Then we have optic disc drusen, which can be superficial or buried, and these make the disc appear edematous. Then we have hypermetropic, a small optic disc on the top left, and here we have optic disc, which has a myelinated retinal nerve fiber adjacent to it. So these discs, they appear to be edematous, but they're not. And this is very important because many times we encounter such patients, and referrals are also there where we are told that we have to rule out papilledema. So we should be aware about these conditions which can mimic papilledema or disc edema. So how to go ahead? So we have to take a detailed history. So visual acuity is very important. We have to see the vision of the patient. We have to take the history. Is there a history of decrease in vision, or there's a history of transient visual obscurations? If the visual obscurations are transient, then we can think of papilledema. And sometimes, mostly in papilledema, the vision is not decreased. Also, we have to take history of diplopia because cranial nerve 6 can be involved. It can be compressed due to this increase intracranial pressure, and patient might complain of diplopia as well. Then pain on eye movements, if present, may lead to a diagnosis of optic neuritis. And headache is usually complained by patients with idiopathic intracranial hypertension, and papilledema can also lead to headache. Then we have to have a visual acuity obviously has to be done. Not only visual acuity, best corrected visual acuity is important because in cases of, as I've seen in refractive errors or hypermetropia, myopia, tilted optic discs, we have a decreased visual acuity. So we have to see whether the visual acuity is improving or not. Then color vision is to be seen. Then blood pressure measurement is very important in such patients because one of the causes of bilateral disc edema is malignant hypertension. Visual fields are to be done to rule out causes like anterior ischemic optic neuropathy. Pupil, as has been discussed, is very important. Relative afferent pupillary defect has to be seen has to be ruled out. So in conditions like optic neuritis, RAPD is very much seen and leads to the diagnosis in most cases. And also OCT, which is now being very commonly used in our practice. So it has to be done, and it is very useful for eventual follow-up as well to see whether the edema is decreasing and how much improvement is there in the patient. So coming to our first thing, how to differentiate between true edema and pseudopapillary edema. So how do we see true edema? So there are 5 mechanical signs and 5 vascular signs. So mechanically we see there's a loss of the cup, then disc might be elevated. Blurring of margins is very important. Obviously there is a nerve fiber layer edema surrounding the optic nerve, and retinal folds, which are called as Peyton's lines, are seen. And vascular signs seen are hyperemia of the disc, venous congestion might be seen, peripapillary hemorrhages are there, exudates and cotton wool spots are there. So this is a picture of an established disc edema. So when we see such a picture, we are obviously sure that the edema is present. But the problem is with early disc edema. So when the hemorrhages are not there, the vessels are not very much dilated. So we have to differentiate that from the other causes of pseudopapillary edema. So vessel obscuration is the key sign. So in true edema, vessels will be obscured, while as in pseudopapillary edema, vessels will be visible, and they can be traced clearly as they climb up and over the hump of the disc without disappearing. Then another factor is spontaneous venous pulsations. Now, spontaneous venous pulsations, they are absent in around 20% individuals. So their absence does not prove anything, but if they are present, that means the edema, that intracranial pressure is normal. There is no rise in the intracranial pressure. In pseudopapillary edema, usually we have a solid lumpy extrusion and the underlying cup is not much obscured. While in true edema, swelling will mostly start peripherally, the margins will be blurred, and then it moves inside. Now we have OCT as well. So OCT structural biomarkers are important. So we usually get it done once the patient is diagnosed, and then we on follow-ups or subsequent follow-ups also we get the OCT done to see for the resolution of the edema. So obviously there is an increased retinal nerve fiber layer thickness. Serial RNFL OCT is useful for monitoring of the response. Then optic nerve head configuration is also important. So smooth anterior bulging of the disc is seen and cup is obviously lost. Then we have a subretinal hyporeflective space. This hyporeflective cleft is seen between the neurosensory retina and the RPE in moderate to severe edema, and it represents fluid transudation from exoplasmic stasis. In follow-up patients of optic disc edema, ganglion cell layer and inner plexiform layer OCT is to be done to see whether there's thinning or increased thickness. Then Brooks membrane deflection. Brooks membrane adjacent to the optic basis of optic disc edema, it will be deflected towards the windshield. With the drusen's, so it will be bumpy, while in edema it will be more regular and elevated. Then there is a fluid collection, and Brooks membrane is also pushed a little anteriorly, and the thickness of fiber there. Then we have to obviously distinguish drusen's, so we go for fluorescein and fundus and autofluorescence. So if we cannot see on that, then B scan is the gold standard, and optic sheath widening, if present on B scan, will suggest intracranial pressure increase. CT scans can also be done to see optic disc drusen's, which will then capture drusen's only if the sections may contain the drusen that is present. Now, once we are sure that edema is true, there is no pseudopapillary edema, so then we have to distinguish the various causes. We have to differentiate the cause of different causes of the true edema. So we have to see whether the edema is unilateral or bilateral. Bilateral edema is present, so we start thinking about papillary edema. First and foremost, we should be measuring the blood pressure of the patient. So blood pressure is a very simple not even an investigation. It is a simple thing that is present in our clinics. So first we should do the blood pressure of the patient, measure the blood pressure, so to see whether it is increased, because malignant hypertension can be associated with bilateral disc edema. Then we think about idiopathic intracranial hypertension, especially in a young obese female of childbearing age who is presenting with headache and bilateral papilledema with preserved vision early. So such females, they should be examined, and idiopathic intracranial hypertension is to be thought about. So once papilledema is diagnosed, we are sure that the edema is true and both bilateral edema is present. So we have to go for an MRI. So if any lesion is seen, any intracranial tumor, meningioma, or any other such lesion is seen, then we are sure that this is the cause of papilledema. But if the MRI is normal, that is when we start thinking about idiopathic intracranial hypertension. So in that, we have to review the MRI ourselves to see for empty sella, any posterior globe flattening, optic nerve sheath distension. And if we are not able to find anything, then we should go for venogram, magnetic resonance venography in such patients. So that will show us venous stenosis. Obviously, weight loss and acetazolamide and all these things are useful for idiopathic intracranial hypertension treatment. Then in a patient who has a sudden painless decrease in vision, and when we see the optic disc, one disc has edema and the other disc is small, crowded, which is called as disc at risk. And in such patients, we can go for, if we go for a visual field, if the vision is not very much decreased, and we go for a visual field, longitudinal visual field loss will be seen. So in such patients, we diagnose the patient to have non-arthritic ischemic optic neuropathy. So there is no proven treatment. We have to go for systemic control and also screen for sleep apnea. And we have to save the other eye because this eye has already decreased the vision, and then we can only go for systemic betterment of the patient. Also, any patient more than 50 years of age with sudden vision loss and disc edema should be treated as arthritic AION until proven otherwise. So this was about papilledema and ischemic causes of optic neuropathy. Now coming to the very important demyelinating diseases. Now optic neuritis has been associated with multiple sclerosis from years, but now it is no longer multiple sclerosis or not multiple sclerosis. We have other spectrum of optic neuritis, which contains certain atypical optic neuritis. These two disorders, neuromyelitis optica spectrum disorder and myelin oligodendrocyte glycoprotein antibody associated disease, or also in the spectrum. Now, these are suspected in patients who have severe bilateral optic neuritis or severe disc edema. So, in these patients, we have to go for MRI of brain and orbit with contrast is to be done in every patient who is diagnosed with optic neuritis. But we have to rule out these disorders also. So, for that, we have to test the patient for antibodies. So, we have aquaporin 4 and MOG antibody for these disorders. And bilateral disease is very commonly seen in these disorders, and now in our clinical practice we are seeing such patients, so we have to keep these in mind when we suspect the patient to have optic neuritis. And blood workup is also as important as the MRI for further to know the further course of disease and for treatment and for the follow-up of the patient. So now we should know that how to, in the end, just coming to how to go further on the patient. So first we have to differentiate whether the edema is true or it is not true. It is pseudopapilledema. So once we are sure about that it is true papilledema, only then we have to go with the investigations, because there are many investigations. Everything depends on our diagnosis. So we have to be sure about the edema present. Then we have to see for the vision of the patient, whether the vision is decreased or not. If it is not decreased, then we have to think about papilledema and causes which are relating to papilledema. If it is demyelinating and ischemic causes are more commonly associated with that. So in cases of bilateral edema, we have to get the blood pressure measured. Obviously, you have to start with that. Then we get the MRI done or MRV done, and when everything is ruled out, then we can go for lumbar puncture. That is also important because we have to rule out meningitis or any infective cause of this increased intracranial pressure. And if the edema is unilateral, then we, keeping in mind the age of the patient, whether pain is there or not, RAPD is there or not, we have to start classifying. First, we have to see whether the patient has pain, and if the patient is young, we think about optic neuritis. If the patient is elderly and the vision is decreased suddenly and painless, decrease in vision is there, then we think about anterior ischemic optic neuropathy. And if the edema is painless and progressive, then that is a dangerous sign. Any meningioma or any tumor can be causing this edema. So we have to go, we have to think likewise, and we, depending on the MRI and its findings, we have to go about it. So obviously we have to differentiate early whether the edema is present or not with OCTs and B scans. And in bilateral edema, if nothing else is seen, then venography is to be done. Then antibodies are to be tested in atypical optic neuritis, and systemic factors have to be treated. Thank you so much.
Thank you so much, Dr. Tulika ma'am, for the presentation. I feel like as PGs, we've all been through this one point where we didn't know how to differentiate the papilledema from the pseudopapilledema, and we've all like struggled and gone to our seniors. And even if we came upon this diagnosis, okay, this is papilledema, what to do next? Nobody knows. We've all been through that stage. So thank you for this presentation, ma'am. The talk is now open for discussion with the expert panelists. Can we please have Dr. Muralidhar sir for his input? Dr. Muralidhar sir, do we have you? Can we please have Dr. Virendra sir?
Yeah, thank you. I think it was wonderful talk. We all agree that papilledema is a very important entity, and everybody has seen those cases, and the challenge is always there. One thing I would like to reiterate for benefit of everyone from the clinical aspect is that in a patient with bilateral disc edema, always keep in mind that this could be malignant hypertension itself, where entire thing and management would change just by looking at the patient's blood pressure carefully. And most of the time, the picture is full blown. You see disc edema, you see hemorrhages, you see soft exudates over there. There will be splinter hemorrhages. The differentiating feature usually from papilledema is that you see that the findings are not just confined to peripapillary area, but over the posterior pole. In a full-blown picture, that is very easy. But at times, malignant hypertension or accelerated hypertension may have only severe attenuation of arterioles. So, and few soft exudates. So that can be a little bit challenging, but that is something that we should keep in mind always. The other closest mimic might be an autoimmune disease like SLE, where you can have picture like this. At times, the retinal pathologies would be the cause, and patients with uveitis, patients with retinal vascular occlusions, VKH, are also quite common. So look within the retina, look for the systemic diseases, look for the signs in the retina. That would also be important. There was a significant discussion about the optic disc drusen, which is one of the most common causes of the pseudodisc edema. So that is important. And now we have more tools that help us pick up these early rather than just B scan and the calcification seen on the autofluorescence. We can also use the enhanced depth imaging OCT that can be helpful in these patients. When approach to a patient requires, keep that also in mind, that is it more likely to be an optic neuropathy, that is papilledema with vision loss, acute vision change, and a central scotoma-like presentation, or if it is more like a papilledema with slow gradual loss of vision, blurring of vision, episodes of TBOs, headaches as the adjoining complaints. So the picture would be different. And in a male patient, do not think that diagnosis would be more likely to be IIH, but more likely to be a cerebral sinus venous thrombosis because male patients with IH are much less common. So these are some just few clinical points I wanted to add. Would be, I think other experts can add a lot of other points. Thank you.
Thank you so much, sir, for your input. Can we please have Dr. Niranjan Perez, sir?
Okay, so thanks for the nice talk, Dr. Tulika Gupta. Just to add a few points, especially from the exam for the postgraduates. Number one is the examiners are quite fond of asking this present scale, though we don't use it routinely, but you are expected to write it for theory as well as for Viva. They would ask what is grade 1, 2, 3, 4. It's very easy to remember. Then second thing about the venous pulsations, Dr. Gupta mentioned about it in her talk. But for the exam, you may need to know what is positive pulsation, negative pulsation. Where do you see positive pulsation? What is arterial pulse, venous pulse? What is spontaneous and what is induced pulse? So all those minor details of venous pulsations would be helpful for your exam. And again, as I said, for the visual field effect, if the examiner asks you, okay, there is papilledema now, what would you do next? Again, papilledema is bilateral disc edema with raised ICP. Either the clinical symptoms or neuroimaging features or lumbar puncture shows the opening pressure is high. So there should be some evidence of raised ICP. Without that, we cannot say papilledema. It is bilateral disc edema. So don't jump on to neuroimaging directly. We should say, I would assess the visual acuity, pupillary reflexes, visual fields, check for blood pressure, and then I would think of neuroimaging. So these are some of the tips for the exams. Thank you.
Thank you so much, sir, for your input. Dr. Kumodini, ma'am, can we please have input from your end?
Okay, she has covered most of the causes of this disc edema. And one thing I would like to say that the perioptic neuritis is also, which also present as a disc edema. And there the visual acuity remains normal because the central fibers are not involved, the peripheral fibers. So there's generalized constriction of the field, more commonly seen tubercle meningitis, sarcoidosis, syphilis, and IgG4 related orbitopathy. Even in thyroid, there is a disc edema, and which is from the peripheral side. So the nerve is compressed by the enlarged muscles. So you will get the disc edema with normal visual acuity. Then another condition is papillophlebitis. That is also a CRVO type of occlusion, which is not ischemic, and it occurs because of mainly inflammation of the central retinal vein over the disc in the young persons. So that is also called enlarged blind spot syndrome. Then for papilledema, important to see when there are with the disc bilateral disc edema, there are associated headache or not. A severe headache, nausea, vomiting, and that suggests more of a increase in intracranial pressure features, and one should think that's the case of a papilledema. Sometimes we get a patient with a disc edema in elderly one, more than 60 years of age, with sudden loss of vision. And there's a disc edema, which is a pallid disc edema. The disc edema, the disc is not hyperemic, the disc is pale and edematous, and the sudden loss of vision in the patient is 60 years. So that is also ischemic, but it is an arthritic type of ischemic optic neuropathy. So you should keep with a giant cell arthritis, which can be occurred without any associated superficial temporal artery or other feature, jaw claudication, or the scalp tenderness and weight of loss, and other features might be absent. The patient just presents with the arthritic type of NAIN. So these patients, whenever you get elderly person who have a disc edema and a pallid disc, totally pale disc, usually the edematous disc are hyperemic, but that the pale disc that's there, then they all ancestry then always ask for inflammatory markers like ESR and C-reactive protein, and palpate the superficial temporal artery tenderness and its texture, how is it firm or nodular or what. So that one possibility you should keep in your mind. I think rest of the points were covered by rest of the people, doctors, panelists. Okay.
Thank you so much, ma'am. Dr. Murlidhar, sir, can you please have a few words from your end?
Yeah, so thank you for the excellent presentation, Dr. Tulika, and expert comments by the panel. I have a few points to add. One is that one is a very favorite exam question. Can patients with optic atrophy have disc edema when the intracranial pressure rises? So the answer is maybe not, because in optic atrophy the axons are lost, and the disc swelling is because of an exoplasmic stasis. So if there are no axons, there is no exoplasmic stasis, and patients with optic atrophy can have a raised intracranial pressure, but they may not have a disc edema. The other thing is, many examiners are fond of asking what is the nature of headache. I mean, you say it's headache, but what is the nature of headache? Generally, it is early morning headache. It's a global headache, worsens with Valsalva, and associated with a transient visual obscuration, which is often postural. So if you have a transient visual obscuration in the setting of optic disc edema, it is very, very significant. The other important question that you are supposed to ask is, do you have diplopia and do you have tinnitus? So both of these can be common, and ask for history of a recent weight gain and if they are on any hormonal medication. So the investigation of choice in patients with disc edema where you have a neurological cause that is suspected, you should get a MRI brain with contrast and MR venography. So many examiners are particular with adding that you have to use contrast. So because many lesions may be missed without the use of contrast, and even MR venography is not very sensitive in differentiating between a true transverse sinus stenosis and a pseudo transverse sinus stenosis. So many examiners are very particular with you mentioning that it should be MRI brain with contrast and MR venography. And of course, do not forget to mention that you have to record blood pressure in these patients. So the other, this thing is based on the other examiner question, is based on the appearance of the disc. How can you differentiate between true and pseudo disc edema? One is, of course, the obscuration of a small blood vessel, which is very much in favor of true disc edema. Second is the presence of a splinter hemorrhage. So that also augurs that it could be a true disc edema. And yeah, the other clinical features that you need to look for in these patients is one is the presence of cells in the anterior chamber and cells in the vitreous, because even inflammatory lesions can cause optic disc edema. So you may have a patient with disc edema who has pars planitis, and you may be mistaking it for intracranial lesion. So please look for evidence of anterior and posterior segment inflammation while evaluating these patients with disc edema. And in addition to visual fields, what Dr. Virender has mentioned, you have to get enhanced depth imaging, EDI, OCT EDI of the optic nerve, which can let you image right through to the choroid. All the recent swept source OCT machines have it. And most of the spectral domain OCTs also have this enhanced depth imaging. So you want to do an enhanced depth imaging. And the characteristic of optic disc drusen in this OCT is you have a hyperfluorescent margin with a hypofluorescent core. That is what is typically described for patients with optic disc drusen. And I guess the other clinical signs have been mentioned. Regarding the spontaneous venous pulsations, the examiners are very fond of asking that. So it is not a very sensitive or a specific sign for differentiating disc edema. But if you had a patient who had documented spontaneous venous pulsations earlier and now has disc edema and the venous pulsations are absent, it is possible that you are dealing with what is likely a true disc edema. So, and again, you can diagnose IIH. IIH has got very specific criteria. So unless unless you meet those criteria, it is better not to mention IIH as the first differential diagnosis. You can just mention it is disc edema, likely because of raised intracranial pressure. That would be a very diplomatic answer, because a raised intracranial pressure can be because of intracranial space occupying lesion, or it can be because of IIH as well. So you can just get away by saying it's a raised intracranial pressure. And in case you have a obese middle-aged female with recent weight gain, then you may put IIH on top of the diagnosis, but you have to mention pending investigations. Don't commit to any specific diagnosis in the exam without a rider to it.
Yes, sir. Thank you so much, sir, for your input. It's really going to be helpful for PGs, I'm sure. Can we please have Dr. Ambika ma'am now for her? Can you please say a few words, ma'am?
I think most of the points are covered by the speakers and the panelist. I just have a couple of points. It's been repeatedly mentioned that IIH is always in the obese females, but we also see a lot of thin females who are anemic also with a florid IIH. These are fulminant ones. So we have to watch out for those. Other than men having a papilledema and a suspicion for a IIH, always consider an anemia as a cause in thin females coming with IIH features. And the other thing is, I just want to slightly differ from one point what Dr. Tulika mentioned. She mentioned that 50 plus, we can go ahead and make a diagnosis of NAION as a diagnosis for a disc edema with a visual loss. Maybe if we have a pallid disc edema, yes, we can agree with that. But of late, we have lot of MOG associated optic neuropathies also presenting in that age group, because we have lot of atypical optic neuropathies in our part of the world. And we have MOG as one of the common differential. Maybe I myself, when I go back and see my cases, which I made a decade back, a diagnosis of NAION with a marginal vision recovery, I do be skeptical that was it a MOGAD which got diagnosed as an NAION. So always do remember that our GCAs are slightly less than the white population. Our atypicals are more. Our MOGADs are more. Our MOGADs and atypical neuropathies are usually painless. So 50 plus painless sudden vision loss need not be only an ischemic optic neuropathy. Keep the options open for an atypical optic neuropathy, and the investigations do also has to be included. And always do document the disc appearance. So document when you follow up these patients, get a photograph, get a structural evaluation with OCT. Always do get an optic nerve cube, check for the RNFL thickness. At the same time, also get a macular cube. Watch for the ganglion cell layer and a IPL layer changes. Because many a times we see the ganglion cell loss to be picking up the early sign than the RNFL to show up with. So always document with that. Other than, we always do a visual fields for the functional marker. So that is done. And other thing is, if at all we document them, do always get the adequate protocols. Like visual fields, it should be only a center 30-2. If you get an OCT, better get the same machine OCT in the successive visits also, because there can be a difference between machine to machine in the follow-up protocol patterns. So these are some points which I thought can add up. Thank you.
Thank you so much, ma'am, for your input. Moving on to our next talk, we have Dr. Sanjana, Sanjana ma'am, who will be giving a presentation on imaging in neuro-ophthalmology. Can we please have you, ma'am?
Good evening, everyone. Firstly, I would like to thank AIOS GuruSangam for this opportunity. Am I audible and is my presentation visible?
Yes, ma'am. Ma'am, you're audible and your presentation is visible on the screen.
Imaging in Neuro Ophthalmology. Is it full screen? Okay.
No, yeah, it's down. All good.
Okay, so my topic for today is imaging in Neuro Ophthalmology. As there are no financial disclosures, as ophthalmologists, we are often the first clinicians who are seeing a patient with an intraorbital or an intracranial lesion. In the last few decades, there have been a lot of improvements, advances in imaging modalities. So knowing about the various techniques which are available, how they are, the different sequences, they will help us or guide us in prescribing the proper evaluation in patients. So what are the different imaging modalities available? The main ones include the CT or the computer tomography, the MRI, and the different angiographic techniques and functional imaging techniques. We'll go through them one by one. A CT scan or the computer tomography. Basically, tomography refers to a process of generating a 2D image slice of an organ of 3 dimensions. And so CT is a digital tomographic technique in which beams of X-rays pass through the tissue which is being examined. And based on the tissue density, there is an attenuation of these X-rays. And based on the amount of attenuation, an anatomical image of the plane being examined is reconstructed. Next, based on the tissue density levels, there are assigned values which are expressed in Hounsfield units on a grayscale. So accordingly, a bone appears dense with about plus 1000 Hounsfield units, and air is about minus 1000 Hounsfield units. So all the tissues appear on a grayscale. Next, a CT scan is especially useful for imaging the orbit because the fat provides excellent contrast And any lesions which involve the bone, lesions that contain calcium, can be easily visualized. Next, the images that we see on a CT scan, we see it in 3 different planes: the axial, the coronal, and sagittal. So first, when we look at an image, how to make out which one is it? So in an axial, this is for the PGs as such. An axial image is when you visualize, when both the orbits are visualized and the brain tissue is behind. This is an axial plane. If you're observing, if both the orbits are visualized and the brain tissue is above, this is a coronal plane. And if you're observing only one orbit, if only one orbit is visualized and the brain tissue is above and behind, that is a sagittal plane. Next, a coronal plane. So this is a coronal plane of the orbit. This is especially useful for examining the orbit in order to pick up a bony lesion. The sinuses are visualized very well. The extraocular muscles are visualized. This is a coronal plane. And this is an axial plane in which we can also visualize the optic nerve and the optic canal. Next, the radiologists also use a technique called windowing, wherein they adjust. I've already mentioned about the grayscale. So now these grayscale, the window width and the level can be adjusted to focus on specific tissues. Accordingly, there are 2 windows in which we'll get in a CT film: a bone window and a soft tissue window, or a parenchymal window. What is the bone window? In this one, the grayscale is adjusted so that you will so this is a bone window. In this one, the grayscale is adjusted so that the bone is very well visualized and the soft tissue contents will merge into it. That is, you will not see the details of it as well. Whereas this is a soft tissue window where the bone might appear as just a whitish entity, but the soft tissues are better visualized. So when you get a film, you will see the different planes, you will see the different windows, and you will see where it has been taken. Next, also the images that you visualize can be better enhanced by the use of a contrast. The contrast which is used in CT scan is an iodinated contrast. Now, so how does it work? Basically, a contrast is intravascular. Only whenever there is a breach, disruption of the blood-brain barrier, which can happen in case of inflammatory or neoplastic processes, they will cross the blood-brain barrier and will be visualized. So use of a contrast will enhance the soft tissue details. Next, so who are the patients in whom the use of a contrast is contraindicated? The contrast which is used in CT scan is iodine. So patients who are allergic to iodine compounds, or patients with hyperthyroidism, and of course any patient with a poor renal functions, the use of this contrast is contraindicated. What are the indications per se for CT scan? Any bony pathology or to pick up any soft tissue calcification, CT is very good. In trauma cases, when you want to pick up a fracture, or in acute hemorrhages, in emergency scans, where example, the patient may not be cooperative for a very longer examination, or to pick up a subarachnoid hemorrhage, CT scan is good. And of course, it is the modality of choice to pick up a metallic foreign body, or whenever it is suspected. And any other case where the MRI is contraindicated, which I'll be mentioning later, CT becomes an indication. Next, so what are the advantages of CT? It is low cost, it is relatively inexpensive. You have a rapid image acquisition, it's widely available, and also accurately identifies lesions, especially in trauma, hemorrhages. So these are the advantages. What are the disadvantages of CT? CT scan basically uses ionizing radiation. So therefore, it is not the preferred modality in children or in patients where you need a repeated examination. Also, the soft tissue resolution in CT is lower when compared to an MRI. And also the chances of allergy, iodine is more, there are more chances of allergy in contrast studies in CT scan because iodine is more, causes more of an allergy. Next, most common imaging modality is MRI, or the magnetic resonance imaging. This is an imaging method of choice because MRI provides excellent details of the CNS tissue, the anatomy, and the pathology. The basic physics of it, this is based on the principle of excitation and relaxation of protons. And that is, the human body contains, the cells contain the hydrogen atoms, the protons. Now, so when the person lies in a strong magnetic field, that is in the MRI machine in the tube, all the protons will get aligned in a single direction. Later, these protons are excited by an external pulse, because of which, once they're excited, and later, once the pulse is off, they relax. During this time, they will release an echo. Now, whatever echo is released is studied, and this signal strength is determined by the tissue-specific parameters. So this is the basic physics of it. So according to that, we have the different sequences. I'll not be going to the details of it per se, But the common sequences include the T1 weighted images, T2 weighted images, the fat separation techniques, FLAIR, DWC, DWI, and ADC, and other techniques, other special techniques. The T1 weighted images. And this specifically is better for demonstrating anatomy. And the T2 weighted images demonstrate pathology better because they pick up any edema better, and most of the pathologies are associated with edema. So T2 weighted images demonstrate pathology better. So when you get a film, how do you identify whether it is a T1 weighted image or a T2 weighted image? So for that, what you can look for is the fluid-filled cavities. So what are the fluid-filled cavities that we are saying? If in the orbit, the aqueous or the vitreous humor, or in the brain, the presence of CSF. These are the fluid-filled cavities. So generally, in T1 image, the fluid-filled cavities are hypo-intense. That is, they are dark. So as you can see in this first picture, the eyeball appears dark, and the CSF, this is dark. So this is a T1 weighted image. Next, how do you make out the T2 weighted image? In this, the fluid-filled cavities, that is the vitreous, the aqueous humor, and the CSF appear hyper-intense or bright. Next, coming to the next sequence, the FLAIR sequence. Basically, as I mentioned, as you can see in this image, there are certain other features. For example, I already mentioned that the CSF in the ventricles is hyper-intense. So when you want to pick up a lesion, a subtle lesion which is adjacent to a bright lesion, you may not be, because that bright lesion might mask a subtle lesion. So you want to suppress this normal hyper-intense lesion. This is done by a technique called FLAIR, which stands for fluid attenuated inversion recovery. So what is done is that this is especially useful in order to pick up a periventricular demyelinating tissue, demyelinating plaques, especially as all of us know for multiple sclerosis. So how does it work? So this is a FLAIR sequence. How do you make out? So this is basically a T2 weighted image. A FLAIR is also a T2 weighted image, but the difference is that whatever is the fluid is suppressed, because of which the vitreous and the CSF will appear dark. Next, of course, so how do you make out then? Because it's appearing dark, then how do you make out whether it's a T1 weighted image or whether it is a T2 with FLAIR sequence? For that, you will have to look at the brain, the gray matter of the brain. So just like in a T2 weighted image, the gray matter is appearing hyper-intense in a FLAIR sequence also, even though the ventricles are appearing hypo-intense. So this will help you to identify what sequence it is. Next, similarly, other special sequences include the diffusion weighted image and apparent diffusion coefficient. These are basically special sequences. They are sequences in which the contrast between the tissue is determined the amount of diffusion of the water molecules. That is, it depends on whether there are free water molecules or bound. So, and based on how easily they can diffuse, we can pick up, this is specifically or commonly used for picking up. This is used specifically to pick up an infarction. The DWI and ADC is used to pick up an acute ischemic infarction, and this will help in management. Basically, in order to determine whether to know if it's an ischemic stroke or if it's an hemorrhagic stroke. And hemorrhagic stroke might be picked up easily, but an ischemic stroke may not be apparent within the conventional MRI might take a few hours to pick up. Whereas the DWI, this image sequence, can pick it up within minutes. So it helps in management to initiate the thrombolytic therapy. Next, as I mentioned, just like we suppressed the hyperintense lesion of the CSF in FLAIR sequence, similarly, the fat in the orbits are also hyperintense. So when we want to visualize the tissues, any bright tissue or any hyperintense signal adjacent to it, it can be masked by the bright signal from the fat. So these fat suppression techniques are used to eliminate the bright signal and help us to visualize the tissues better. So this can be in the form of either fat saturation and the STIR, or which is the short TOR inversion recovery sequences. This can be used and to pick up the optic nerve lesions better. Next, coming to the similarly, just like an CT image can be enhanced with the contrast, an MRI image can also be enhanced with the contrast. The difference, the contrast which is used in MRI is gadolinium, which is a paramagnetic substance, and this also crosses a disrupted blood-brain barrier and alters the signal characteristics. So this can be used in identifying infections, inflammations, and certain tumors which would otherwise be indistinguishable from a normal cortical tissue. For example, in optic neuritis and a meningioma, contrast is to be used. And of course, just like anything in a renal disease, the use of a contrast is contraindicated in renal disease. So this is an image, this is a T2 weighted image, which is showing us, yes, that there is an optic nerve pathology, a glioma, but a T1 weighted image, and the gadolinium contrast is used, it's a T1 weighted image. So in this image, the T1 weighted image has been enhanced with gadolinium, and as we can see, the image is very much more enhanced. Other than these, there are certain other sequences. This is Fiesta sequence, CIS, which stands for constructive interference in steady state, and Fiesta, the fast imaging employing a steady state acquisition cycle phases. These are advanced MRI techniques. They provide superior detail for diagnosing complex neurological conditions where the standard MRI sequences fall short. This is by making a fluid spaces and nerves stand out. Specifically, indications, clinical uses in neuroimaging, these sequences can be used for evaluating cranial nerves, detecting vestibular schwannomas. Also, it can be used in pituitary imaging to pick up a very small pituitary adenomas also can be used. Next, so coming to the MRI, what are the advantages of MRI? It is, as compared to CT, it is not an ionizing radiation, and it provides superior soft tissue resolution. Also, the contrast agent in MRI is better, this gadolinium is better tolerated than iodine. Disadvantage, the test takes a longer duration. When compared to a CT, MRI is of a longer duration. And so this also requires a patient cooperation because a patient needs to stay still without moving in an MRI machine. So this is, so it requires a patient cooperation in a trauma patient with an altered sensorium. It's difficult to do an MRI. Also, MRI is of a higher cost when compared to CT. Next, so coming to what are the patients who MRI is contraindicated? As I mentioned before, this is an evaluation where the patient is placed in a strong magnetic field. So anything which can get affected by the magnetic field, if the patient has anything like a cardiac pacemaker, any suspected metallic foreign bodies, aneurysmal clips, cochlear implants, MRI is a contraindicated. And also the tube per se, the tube per se is like a closed, is closed. So patients who are claustrophobic may find it more difficult to undergo an MRI when compared to a CT scan. So these are the relative advantages, disadvantages, and the contraindications of it. Next. Coming to the vascular imaging modalities. That is, imaging the cerebral vasculature is important for many of the diseases that we see as neuro-ophthalmologists, whether to pick up an aneurysm, vascular occlusions, AV malformation, dural venous sinus thrombosis, arterial dissections, vasculitis. All of this we need to image. So what are the different modalities which are available for vascular imaging? And angiography can be combined with an MRI, with a magnetic MRI, and we have a magnetic resonance angiography and an MRV. So what is the unique feature of this is that the flowing blood per se, that itself acts as a contrast. And so without a contrast also, this can be done. The moving bloodstream provides a clear view of the intracranial vascular structures, even with or without an intravenous contrast. This can be used for visualizing the proximal large vessels of the chest and the neck, but may not be very good for picking up a smaller aneurysms. Next, CT imaging. Similarly, a CT imaging also can be combined with an angiography, the CT angiography. This utilizes but this, as against as MR angiography, this requires the use of contrast medium, the same contrast medium. And there is a reconstruction done. A software allows control over the viewing angle and the amount of degree of transparency of the non-vascular tissue. CTV is an excellent modality for visualizing the cerebral venous system and is less susceptible to artifacts than MRV. Next. So this is a CT image showing a carotid aneurysm. Next. But the gold standard for the vascular imaging is conventional catheter angiography. This is an invasive procedure where a catheter is placed intra-arterially and then an iodinated radiodense contrast dye is injected. Of course, this is a gold standard, but because it's an invasive procedure, this can be associated with complications like vasospasm, emboli, and also the contrast which is used can also cause an allergic reaction. So right now, this is not, it is only done if for the CT or the MR angiography is inconclusive and if it's really needed. Next, there's also a technique called DSA, the digital subtraction angiography. This is a technique that reduces the artifacts by subtracting the densities created by the overlying bony skull. So what does it mean? See, normally when you see the blood vessel, this will also be surrounded by the bony skull. In this, whatever the skull images are there, they are digitally subtracted so that you see only the vascular system. So this is an image which is showing an aneurysm of the posterior communicating artery. So all of these were about structural imaging. Mostly this is what we do, a CT scan or MRI, but we should also know something about the functional imaging. The functional imaging modalities include magnetic resonance spectroscopy, the positron PET scan, positron emission tomography, the SPECT scan, and also functional MRI images. So what is the magnetic resonance spectroscopy? This is basically an in vivo biochemistry. It helps in visualization of the biochemical and the molecular composition of a specific tissue or a tumor. This, as we can see here, it will help us to know the composition of a specific tissue. And next, functional imaging. Functional imaging, they help in visualization of the small changes in the blood flow associated with a specific brain activity. Basically, they measure the blood flow. Whichever region is more active will have more blood flow. So they will, in this functional imaging, it tends to pick up these. MRI perfusion again visualizes the change in brain perfusion. So briefly, where is it useful? Functional images can be useful in cases of cortical visual impairment, where there's a normal MRI, functional imaging can be useful. So in brief, to compare, what is the comparison of CT and MRI? CT, better for bony abnormalities, to pick up an orbital and an hyperacute intracranial hemorrhages, to detect calcification of the lesion. And this is more widely available. Of course, there is with the disadvantage of an ionizing radiation and iodine-based contrast time. Also, CT scan has limited resolution posterior fossa and a poor resolution of the orbital apex. Whereas MRI, this has good soft tissue resolution, can distinguish white matter from gray matter, can better depict posterior fossa pathology when compared to CT scan, can also show the evolution of the intraparenchymal hemorrhage, and does not use ionizing radiation. So as of now, for most neuroophthalmic indications, MRI is a treatment of modality of choice, except the other entities that I have mentioned. But the disadvantages and the contraindications I've already mentioned. Next. Other than that ultrasonography, it's a rapid, non-invasive and inexpensive technique for imaging. This can be used to image the carotid arteries, the orbit, and the globe. This is based on the reflection of the ultrasound waves at acoustic interfaces. All of us are aware of the use of ultrasound for the imaging of the globe. Specific conditions in neuro-ophthalmology, a carotid Doppler can detect a carotid artery stenosis, but it's not as good in picking up a carotid artery dissection. An orbital ultrasound can show the reversal of a normally retrograde venous blood flow in CCFs. And also it can be used to distinguish, as already mentioned, to discuss an optic disc edema from an ONH drusen. So this is an image. So a B scan when you are suspecting to differentiate pseudopapillary edema. Next. So after learning about the different imaging modalities, so what are the common clinical scenarios for which we prescribe an imaging? So what are the conditions that the patient comes with? So for an unexplained, a unilateral or a bilateral vision loss. That is, for example, if there is a transient vision loss, like amaurosis fugax. If there's a unilateral or a bilateral optic neuropathy, junctional scotomas, bitemporal hemianopias or other visual field defects, any of these field defects. In cases there is a neurogenic pupillary defects, different defects, for example, suspecting a Horner syndrome or a third nerve palsy, or a RAPD, light near dissociations, or orbital imaging in cases of proptosis, which can also be due to a cranial lesion like a keratoconcavenous fistula, diplopia or external ophthalmoplegia, eyelid abnormalities, nystagmus, ophthalmic abnormalities such as papilledema, an optic atrophy, optic nerve hypoplasia, or an ocular or an orbital trauma. All of these are the common clinical scenarios for which an imaging study might be prescribed by us. So when you're prescribing, what are the guidelines when you're ordering an imaging study? So based on this, after taking your history and an examination, you will decide on the modality. As I mentioned before, MRI is superior to CT for most neuroophthalmic indications, but CT is superior for calcifications, for bone, for acute hemorrhage, if you need an emergent scan, or if the patient cannot undergo an MRI. When you decide the modality, you will decide if the contrast is needed or not. In most cases, contrast should be ordered for both CT or MRI. But it is not necessary, or it is not to be used in acute hemorrhages, thyroid eye disease, and trauma cases, because some it can mask acute hemorrhages, it can mask. Also check for contrast contraindication before you prescribe it. Next, basically topographically, when you order an image, in your mind, you should topographically localize the lesion. That means, where is the possible site of the lesion? What are the possible differential diagnosis? Where is the lesion? What is the lesion? How urgently do you need the scan? And then decide on the best study which is tailored for the specific lesion. Do you want to visualize the head, the orbit, or the neck? And after that, you also decide if any specific sequences are required. As I've already mentioned, for example, a fat suppression orbital post-contrast study, a flare sequence for white matter lesions, a DWI for a stroke or a posterior reversible encephalopathy syndrome, GRE for hemorrhage. So see if any specific sequences are needed. Or order if any special imaging is required for a vascular indication, like an MRI with an MRA or MRV, if any specific imaging is required with contrast. Next, if you're not sure what is to be done, discuss with a radiologist if there's a doubt about localization or which is the image modality of choice, whether about the selection of the contrast, the indications, in any thing, discuss with the radiologist. Also, if the imaging shows either no abnormality or an abnormality that is not matching with the clinical localization, then review the films directly with a radiologist. Try to see if the area of interest has been adequately imaged, or if there's any artifact might be obscuring the lesion, and if any additional studies might show a lesion. Also, if the clinical picture suggests a specific lesion or a localization, but the initial imaging is normal, you can consider repeating the image with thinner slices and higher magnification of the area of interest. This is especially if clinically the signs and the symptoms are progressive. And finally, recognize that the lack of an imaging abnormality does not exclude a pathology. What are the errors that we can do when we are prescribing a neuroimaging, when we are requesting a neuroimaging study? The errors could be in terms of prescription, that is, you have failed to get a correct study, but you have got the correct study, but you're not using it appropriately. Either it's through the omission of the intravenous contrast material, omission of specialized sequences. Or there could be interpretive errors. That is, a failure to detect a lesion because of a misleading clinical information. Instead of just writing an MRI brain, MRI orbit, give the clinical information of the patient is very essential. Or rejection of a clinical diagnosis because one particular expected abnormality is absent. Based on that, you cannot reject the clinical diagnosis. At the same time, you cannot incorrect assumption just because it is striking imaging abnormality. So basically, all of this means that the clinical, the clinical correlation is very important. So to summarize, we learned about what are the different imaging techniques available, sequences, what are the reasons why we would prescribe, how we will prescribe. Now, finally, actually coming to the neuro-ophthalmic indications and what is the treatment modality which is ideal. Okay, optic nerve drusen, we have discussed, yes, it can be picked up by an ultrasound. A CT scan of the orbit can show a calcification. So does it require a contrast? It does not require a contrast, and ultrasound is a less costly and a more sensitive than CT scan for picking up a drusen. Papilledema, as we already discussed, MRI with an MRB magnetic resonance immunography with contrast is needed. Also consider contrast, to exclude a venous sinus thrombosis, especially in atypical cases of pseudotumor cerebri. For example, thin male elderly patients, it can be used. Next, the transient vision loss or amaurosis fugax. In this, consider an MRA or a CRT, basically an angiography of the neck to look for any carotid stenosis or dissection. And this might require an adjunctive carotid Doppler study or a catheter angiography. Coming to the demyelinating optic neuritis, it requires MRI head and MRI orbit. MRI orbit with contrast with fat separation to look for an optic neuritis, and MRI head with a flare-specific sequence, which I've already mentioned, to look for any demyelinating white matter lesion, because this has prognostic significance for the development of multiple sclerosis. Any infiltrative, inflammatory, or compressive optic neuropathy, again an MRI head and orbit, again a fat separation to be done. If it's a traumatic optic neuropathy, then CT is superior to pick up any canal fractures where you need a thinner slices. Junctional scotomas, which is the optic neuropathy in one eye and a field defect, superior field loss in the fellow eye, MRI head is to be done with contrast. For bitemporal hemianopias, all the field defects have been discussed in detail. So I'll just mention the imaging. In bitemporal hemianopia, you will get an MRI head with specific attention to chiasma and cella. Contrast is needed. But if in certain conditions, for example, if it's an emergency scan is needed, like a pituitary or a chiasmal apoplexy, you can get a CT scan of the cella. Also, if you want to look for calcification in meningiomas or craniopharyngioma or aneurysm, CT can be done. Homonymous hemianopia, and basically any retrochiasmal lesion, MRI head is done along with the contrast. If to pick up a functional imaging, the DWI can be useful in cases of acute ischemic infarcts. If the structural imaging is negative and organic loss is there, functional imaging can be considered. Next, coming to the other cranial nerve palsies, the third, fourth, sixth nerve palsies or Cavanagh syndrome, MRI head with attention to the skull base is done whenever indicated. Of course, in ischemic isolated, ischemic mononeuropathies may not require imaging. It depends. Once you, rule out that you're sure that it's fitting into an isolated ischemic mononeuropathy, otherwise you will go for an MRI head with attention to skull base. What CT can reveal a rib calcification, aneurysms, calcification in tumors, and hyperostosis can be seen on CT. And I've already mentioned the newer techniques, this CIS and Fiesta sequence for picking up the nerve palsies, oculomotor nerve, the nerve palsy. Next, for INO lesions, MRI head or brainstem can be done. Specifically, rule out any demyelinating or a brainstem lesion, so include a flare sequence. In cases of nystagmus, that is an unexplained nystagmus, MRI brainstem is to be done. With the contrast, hemifacial spasm, MRI to look for the facial nerve compression, the root exitone, MRI brainstem with or without MRI is to be done. Horner syndrome, based on whether it's a preganglionic or a postganglionic lesion, MRI head or neck with to the second class vertebrae can be done.
सर केले सिक्योरिटी गार्ड पार्सल करूंगा
Rule out the lateral
சரிங்களா
medullary
डॉक्टर नंदिता डॉक्टर
apical lung neoplasm carotid dissection. Horner syndrome postganglionic lesion, again rule out a carotid dissection, isolated postganglionic lesions.
हाँ सरी हाँ good.
Because of the paucity of time, I'm not going to the detail what are the findings that we see in each of these, but only on what are the ophthalmic, what are the imaging which is indicated. Next, orbital indications and the recommendations for imaging. If it's thyroid ophthalmopathy or CT or MRI of the orbit, iodine contrast should not be used because the iodine can interfere with the treatment of systemic thyroid disease. So bone anatomy better seen with CT scan, especially if the orbital decompression is being considered. If orbital cellulitis or an orbital disease secondary to a sinus disease, CT orbit and sinuses will help to visualize. MRI can be a useful adjunct to CT scan if there is a possibility of a cavernous sinus thrombosis. Orbital inflammatory pseudotumors, CT or MRI with fat separation can be used. Orbital tumor, again, it depends. Get a CT or MRI based on what lesion you're suspecting. Include a head imaging if the lesion could extend intracranially. For example, in optic nerve sheath meningioma, you can look. If you want to specifically look for any hyperostosis or calcification, for example, in a sheath meningioma, CT can be included. Trauma, in orbital trauma, fractures, periostal hematoma, foreign body, CT scan with a direct coronal image. Contrast is not generally needed, and CT is superior to MRI. In traumatic optic neuropathy, a CT optic canal thin sections, contrast is not needed. A CT is superior for visualizing the fracture. MRI might be superior for picking up an optic nerve sheath hemorrhage. CCF, keratoconus fistulas, CT or the MRI can be done with the contrast in an MRA. This shows an enlarged superior ophthalmic vein. May require a catheter angiogram for the final diagnosis or treatment. A color flow Doppler study may be useful for detecting the reversal of the orbital venous flow. So to conclude, the information that you get is only as good as the information that we give. So imaging study is only as good as the clinical information which is provided to the radiologist. So communication between the clinician and the radiologist becomes the single most important tool, especially when you're solving mechanism to solve any difficult or complicated cases. Thank you.
Thank you so much, Dr. Sanjana ma'am, for going back to the basics and discussing the various neuroimaging. We often, as we go further, we often tend to forget the basics. So thank you so much for covering, ma'am. And ma'am, thank you for compiling all the pathologies and which investigation to prefer in which. Thank you so much. So the topic is now open for discussion. Can we please have Dr. Muralidhar sir for his inputs?
Yeah. Yeah, so one of the common questions that examiners ask is in which patients would you request CT scan and which patients would you require an MRI? So as has already been mentioned, CT scan is primarily for disorders of the bone. Okay, and earlier acute infarcts used to show up on very well on CT. Acute infarcts and hemorrhages in the brain used to show up very well on CT. But with advances in MRI imaging, especially the diffusion weighted imaging, even acute infarcts can be picked up very well on MRI. So CT is good for lesions of the brain. If you're suspecting an intracranial hemorrhage, CT is really good. And if you want soft tissue resolution, if you want to pick up infarcts, MRI diffusion weighted imaging is just as good. And the other important questions that examiners like to ask us, can you differentiate between an ischemic optic neuropathy and optic neuritis based on MR imaging? So for that, you can say that you can actually extend doing diffusion weighted imaging on the on the optic nerves. So diffusion weighted imaging, if it shows a hyperintense signal, that could be one of the supporting evidences for ischemic optic neuropathy. And enhancement of the optic nerve head also is seen in ischemic optic neuropathy, whereas enhancement of the optic nerve per se, any part of the optic nerve, intraorbital, intracranial, is more likely to represent an optic neuritis. Likewise, presence of ischemic changes in the brain, go in favor of an ischemic optic neuropathy, whereas presence of demyelination go in favor of an optic neuritis. So these are, I think, common questions that examiners ask. The other important question is MR angio or CT angio or DSA is the investigation of choice for detecting aneurysm. So MRI is a static MR angiography, while it is very, very non-invasive, doesn't require administration of any contrast. So it actually is a static technique and doesn't really show the filling of an aneurysm. Can miss out aneurysms which are blocked by a clot and those less than 5 millimeters. So CT angiography excels in resolution and is much safer than digital subtraction angiography, which carries a 1% incidence of stroke as far as detection of aneurysms is concerned. But if the talk is about distinguishing a caroticocavernous fistula versus then I guess digital subtraction angiography still is the modality of choice. CT angiography and MR angiography, while they are picking up fast, but I think digital subtraction angiography is still the investigation of choice when you are suspecting a caroticocavernous fistula, because CT angiography tends to miss out many lesions.
Thank you so much sir, for your input. Dr. Kumudini Sharma, ma'am, can we please have you say a few words about the topic?
Like she has covered it very extensively, and there's a very little to add to it. First is like she was saying, the CIS and Fiesta, they are really very good. They can show you the whole trajectory of a cranial nerve, and 6 especially very well. So we had one patient who has a persistent 6 now palsy, that was painful and was not improving. And when we got the CS10 fever, we could find aberrant blood vessels near to it, which was a cause. And even hemifacial spasm, also the around aberrant blood vessels compressing the 7th is most common cause. And one thing is, we should know that contrast is only used in T1 imaging. T2 is never. T2 is just all the modification for the flare, DWI, CSF, PSF, they all modification in T2 imaging. And MRS, we see the peak of these amino acids, choline, lactate, NAA, and creatinine, and lipid profile. Lipid peak. And if there's a choline peak, which is very much suggestive of tumors. And secondly, by MRS, you can differentiate whether it's a recurrence of a tumor or it's a radiation changes over there, like especially in pituitary cases. We get lots of pituitary where there's a recurrence over there, and they had been given radiation also. So sometimes we have to find out what are the field effect or the visual problem we are getting. Is it because of recurrence or it's a radiation optic neuropathy? So for that, MRS helps a lot in differentiating the two of the things. And now we have an aneurysmal clip which are compatible with the MRI picture. So we not like in, and clips are used, so we can't do MRI. And there is a time of flight, sometimes you ask for MRV and MRA, they just do the time of flight imaging. That's the way overdiagnose the narrowing of the venous sinuses. So whenever you are very thinking of that the venous sinus occlusion is the cause for this benign intracranial hypertension, then you should always mention that do MRI or MRV with contrast. And there is a vessel wall imaging, thing which is coming up in the case of GCA patient, giant cell arteritis patient. We have arthritic type. We should have just to replace this by doing the interventional thing like biopsy. They are doing more this vessel wall imaging can help in making the diagnosis of the GCA patient without superficial temporal artery vessel wall imaging. And in any vasculitis, they are trying this type of imaging to like before without doing biopsy we can make the diagnosis, and rest of the things she has covered very well. I don't have to add much.
Thank you so much, ma'am, for your input. Can we please have Dr. Ambika ma'am say a few words about the topic?
Nice talk, Dr. Sanjana. You have covered it very well. And I just have a couple of points. And we all know that MRI is the most common imaging choice in neuro-ophthalmology, and CT have a very limited role, as she has mentioned. And DWI has definite role in aging the lesion, because when we have a vision loss and an optic nerve enhancement, most of the times NAION will not cause a optic nerve signal. If at all there is a bright signal, even with an ischemic optic neuropathy, the non-enhancement will differentiate. And if it is enhancing, it's an optic neuritis. And imaging of the orbital apex is something which we have to be very, very keen. And we have to mention the radiologist to take thin cuts at the level of the orbital apex, because sometimes we may miss the superior orbital fissure and the orbital apex lesions if the cuts are inadequate and if we don't have adequate coronal cuts post contrast. And regarding the contrast, other than all the contraindications what you have mentioned, renal insufficiency is something which we have to keep in mind when we have to get a post contrast imaging for all these patients. And the other thing is, other than DWI, the only problem with diffusion imaging is it's quite time consuming. So we have to put the patient in the console for a longer period. So if it's going to be a DWI or a DTI, because sometimes we may have a negative MRI where we suspect a lesion. In those conditions, like a DWI, a DTI, which is a diffusion tensor imaging, that can also give an added value to localize the lesions anywhere along the visual pathway when an MRI is negative. And always consider DSA, because if it is an invasive procedure, so always when a non-invasive imaging modality is negative, or you get a positive clue on that, then ask for a DSA. Like what, as earlier one of the panelists mentioned, that in case of a low flow AVMs or a CCF, when we have a clinical evidence, in addition to that, if we have an MR imaging evidence of the vascular conditions, then probably we can add a DSA. And the other thing is the location of the mass. If we have a papilledema, our mindset is always we expect a lesion in the brain. But I had once a condition where the patient had a lesion in the spine. So MRI spine is something which we will not even think of when we always make a diagnosis of papilledema. And this patient I had one or two signs where I did ask for an MRI spine, which picked up a huge lesion causing this obstruction, and that's not something which is uncommon. And coming to MRS has a vital role because the Collin peak and the NNA, which peaks will differentiate the type of the lesion, the biochemical composition will be useful whether we plan for a surgical excision or do we plan for an infective workup. That gives a lot of clue by a MR spectroscopy. And coming to the carotid artery imaging, yes, Doppler, it is mostly observer biased. So carotid artery Doppler need not always pick up all the plaques what we are expecting to look in a carotid artery disease. So to overcome that, we may recommend a MRA head and neck if we suspect strongly a carotid artery disease. These are few points what I thought will add some value. Thank you. Good talk, Sanjana.
Thank you.
Thank you so much, ma'am, for your input. It's definitely going to be helpful for the PGs. Can we now have Dr. Niranjan, sir, to give his input?
Okay, I think Dr. Sanjana had already told so much, which was further added on very well by the other panel members. So I don't have much to add. But if it is about the PGs, I would say that they may ask you very simple questions like the image that is put up, is it a CT or an MRI and why? Is this T1 weighted? Is this T2 weighted image and why? And the other modalities like say diffusion weighted imaging or fat suppression and all those things. What's the logic behind these? So a little information about this would be helpful for you. And yes, we have a lot of advances in these imaging modalities, but what is most important in the clinic is the clear thought process. When you see an entity, what is it in your mind that you're looking for on imaging? Where do you expect the lesion to be? Localizing the site of lesion by not only visual fields, but several other things. What do you think the lesion is and where it could be? That logical thinking is most important. And secondly, communication with the radiologist, as Dr. Sanjana had nicely alluded to. We need to discuss with the radiologist because many of the radiologists are not used to reporting things that are relevant for us. They're more used to the common cerebral or the brainstem kind of things, but they may not be used to reporting subtle signs of, say, IIH near the globe. So they may not be used to all those things. We need to slowly tune them to what we want. So a close communication with radiologist is important. And having worked in a resource limited setting where the entire country had just one CT scan, we need to make best use of what we have. So yes, CT scan in our setting is something very easily available and we don't even think of it when it is neuro ophthalmology. But you may be in a setting where you may have to make best use of modalities like even X-ray and CT scan. So that's where this clear clinical thinking and clear communication with the radiologist, seeing the images together would matter. Thank you.
Thank you, sir.
Thank you.
Yeah, I just would like to add to that. Thank you, Niranjan. So you're absolutely right. A communication with the with a radiologist is so important because, and it's important to even give a history of the entirely for the patient, like you give a pathologist. So the same way, it's okay to communicate with the radiologist as well. I have seen a difference in the reports coming because when we started communicating with the radiologist, they started understanding what we need, and I think it's a tuning. And after 5 6 reports of or discussions, they knew exactly what we wanted, and after that we don't ever have to even mention to them. Like for example, in the orbital lesions, as I'm an ocular oncology oculoplasty, so whenever we have these lesions, we always ask them for, like, if it's a schwannoma, I ask it which nerve is it arising from, where is it exactly located, and is it impacting the muscle or not. So when they start reporting that, it's very useful. Yeah, it's absolutely agreeable. And Sanjana ma'am, great presentation. Yes, Nandita.
Thank you so much, Niranjan sir and Rolika ma'am, for your input. Can we please have Dr. Virendra sir to say a few words about this topic?
Yeah, thank you. Wonderful talk, Dr. Sanjana. I think you extensively covered everything, and a lot has been reiterated and added in the discussion. I would like to, I want to limit adding more information on this topic because there is no end to it. If you want to go into details of each disease, the imaging itself is so extensive. But at the same time, for the postgraduates, I think what Niranjan was trying to say, learn the basics, interpret would be very important. Knowing the structures and being able to tell the sequences would be very important from the exam point of view. From the practical point of view, like Dr. Ambika was telling that you might have difficulty and thin sections are needed near the orbital apex. I think another such area is the cavernous sinus lesions that requires a dedicated history and imaging over there. Sometimes you have rare lesions and such as optic nerve says schwannomas arising from different nerves that can be picked up by specific imaging. There are lot of advances and newer techniques are coming up that have validity in each disease. For example, for cerebral sinus venous thrombosis, the current investigation of choice would be MRV with contrast in most of the centers. So these imaging refinements would keep on happening, but maybe you could go through it and look at what is needed. Lastly, but I think that was covered in the talk already. But again, important that they might ask from the postgraduate point of view that where you would prefer the CT over the MRI still. So in trauma, and you might require both CT of the brain and orbits. You want to rule out any fractures, and you want to look out for anything impinging on the optic nerve, apart from the soft tissue damage and rarely hematomas behind. So trauma is one major indication. Suspected foreign bodies is second. Third one is when the patient is contraindicated to have MRI, and fourth one would be where you are in an emergency, you want in a stroke setting, it might still be very important. It can be done very fast to rule out a hemorrhagic stroke. So certain important things would still be important. Uh, Dr. Ambika told about the contraindication for the MRI includes renal failure, but it's a relative contraindication where if the GFR is beyond a particular level, it cannot be done at all or has to be followed with a dialysis on the same day. So lastly, most important is good communication and relation that would be needed. Neuroimaging is a part and parcel of our daily work. Thank you.
Thank
I
you so
just
much,
have
sir.
one comment.
Yes.
It's MRI is not contraindicated in renal function. I'm saying you have to be cautious with the use of contrast for the renal insufficiency. We can just still
Yeah.
get a plain MRI in the renal insufficiency. And as he has mentioned, if the GFR is quite good enough, we can proceed with the contrast too. And
Yes.
we also have an open MRI for claustrophobic patients because most of the time claustrophobia is considered one of the contraindications for getting the conventional MRI. So we can ask for an open MRI if it is really available in your locations. Thank you.
Thank you so much, ma'am and sir, for your input. And thank you, Dr. Sanjana ma'am, for beautifully and elaborately covering the topic and for touching upon the basics, which you often tend to forget, as well as covering the various pathologies in a very compiled manner. I think it's going to be very helpful for the postgraduates and all the viewers watching this. So thank you so much. And with this, we come to the end of our today's session of Guru Sangam Neuro Ophthalmology, session 22. I would now like to call Dr. Rolika ma'am to give the end note. Please,
Thank you
ma'am.
so much. Thank you so much, Nandita. I absolutely agree with the entire discussion. In fact, I would just like to add that as Ambika ma'am and Virendra sir were discussing about thin sections, it is so important that the tiniest of the lesions get missed when they send 3 mm cuts. And even I request them that please give us 2 mm cuts at least so that we can identify the lesions in at least 2 or 3 sections. Otherwise, we are done with it. Even the optic nerve doesn't get seen in more than 2 sections. So that's very important. I'm glad that we added that. Thank you to all the panelists and all the speakers for this wonderful collection that we made for neuro ophthalmology. I think the very important topics have been discussed and which are seen day to day by the residents and the postgraduates. So thank you so much, everyone, for taking out time on your Sunday evening, which is absolutely like a day that is dedicated for everyone individually. So thank you very much for joining us. And thank you, Nandita, for carrying out this session entirely alone. So great. Kudos to you. And thank you, Sunilji, for helping everyone for the technical support. Thank you, everyone.
Thank you. Thank you, everyone.
Thank you.
Good job,
Thank
Dr.
you so much.
Nandita.
Thank you.
Thank you so much, ma'am.
Thanks, everyone, and nice
It
to
was
see
a
you.
very,
Okay, thank you, everyone. Good night.
thank you
Good
so much, everyone. It was a very enriching experience and a very enriching webinar. Thank you so